Good evening, dignitaries and all the participants. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Medicolegal Update, organized by MOX Family Welfare and MTP Committee and MOX Public Awareness Committee. So let me introduce the MOC of today's webinar, Dr. Pratibha Baldhava. Ma'am is a gold medalist and a fellow of American College of Obstetrics and Gynecology. Ma'am is currently the current consultant of SS Baldava Hospital, Solapur. Ma'am is past treasurer and honorary secretary of SOGS and currently executive member of SOGS. I welcome you, ma'am, and I hand over the session to you.
Thank you so much, Sahiti. Can we have the e-lighting for today?
Yes, ma'am.
So that we can begin the webinar. Thank you so much, Sahiti. I today welcome on behalf of the welcome all the esteemed guests for today for the webinar which is being conducted by the MOX Medicolegal Committee. I welcome the chairperson of the Medicolegal Committee, Dr. Komal Chauhan. Can I have a CV, please? Dr. Komal Chauhan is very well known to us. She is the medical director of Chauhan Maternity and Nursing Home. She is a senior consultant, DNB teacher and unit chief, VN Desai Hospital, ex-honorary professor of R.N. Cooper Hospital, chairperson of FOXI Medical Legal Disorders Pregnancy Committee, and zonal coordinator of FOXI 2022-23. She is currently contesting for the vice president post. So we all are in her support. Madam, Dr. Komal Chauhan, madam, I welcome you. Can you please introduce Dr. Rajan Singh Pardesi, sir?
Yes, thank you. Thank you so much, Dr. Pratibha, for the lovely introduction. And it brings really great when we are with our Amox family, We feel so connected and we feel like doing good work. And all this is happening under the leadership of our Pardesi sir with Amox Family Welfare and NTP Committee and along with the Public Awareness Committee. I think Monica is doing great awareness, whenever we want to reach out to all our members as well as to the public. I think the first name which comes into our mind is Monica. So I always call her, and we do a lot of associated programs. So really honored today to do this medical legal updates. Why? Because recently I had been visited the DGP of Maharashtra state, and we have submitted the letters regarding the section 304, that is against doctors. That is, they are charging and implicating our doctors in this serious offense, and also a lot of POSCO cases are coming, and because there was no reporting or whatever, and the doctors are getting harassed. So this was actually a burning issue, and under the guidance of Pardesi sir, we have submitted letters to DGP Maharashtra state, and that was the issue. So I said, let's continue and discuss some of the medical legal issues. And we are so happy that Dr. Alka madam is here as a guest of honor, and all the eminent faculties who have joined. So I welcome you all. And I first introduce our president of AMOX, Dr. Rajendra Singh Pardesi. We all know Pardesi sir, presently the president AMOX, but earlier he was a vice president FOXI. And during his tenure as a vice president, I was a chairperson. So we have worked very, very closely. He has he's not even well known in India, but also all over in world, being faculty at various international conferences also. That is in Taipei, Rome, Italy, and he is recipient of Dr. Meru Dara Hansotia Best Committee Award from FOXI, and that is the appreciation of the work done as a committee chairperson. So over to you, sir, to kindly address and share your vision with all our viewers.
Good evening, everybody. Respected Dr. Alka Kripalani ma'am, our past president FOXI, and ever smiling, ever active academician. We enjoyed her tenure of FOXI, and we still remember her as president in our Sonocon conference at Aurangabad in 2016. She encouraged a lot. respected Dr. Kiranmai, Dr. Sujata Dalvi, our Secretary AMOG, Dr. Monica Ubadan, Dr. Komal Chavan, Dr. Sudesh, Dr. Gorak, Dr. Girish, Dr. Rekha Rajendra Kumar, Dr. Neeraj Nagpal, Dr. Bharti More, Dr. Suyoga, Dr. Stabdi, Dr. Vasade, Dr. Baldava, Dr. Sukla, Dr. Sorupa, Dr. Nalini and friends. First, I wish to express my sincere thanks to Dr. Alka Kuplani for addressing us. I am feeling proud to honor to be a part of this webinar and this program and to share the dais with Dr. Kulpani. I wish to congratulate Dr. Komal Chavan and Dr. Monica Ubandan for organizing such an academic and practical webinar on medico-legal issues, which is really useful in day-to-day practice and now a burning problem facing all the members, not only from Maharashtra, but all over India. We are facing this problem. We know there are too many problems we are facing due to POCSO Act. Not only practitioners, but even government sector of gynae also are facing problems in registering for ANC, for MTP, and for every procedure. We have to either inform police or sometimes we have to do police cases. There is no uniformity in the implementation of this law all over. As Dr. Komal told, AMOGS has submitted a request letter to seek guidelines for registering ANC case, MTP, operative under age of 18 and married under POCSO Act. So Dr. Komal Chavan and Dr. Gorak Mandrukar, these two people are instrumental in making this draft and submitting to Director General of Police and all authorities in Mumbai also. And soon we are submitting all over Maharashtra, means Superintendent of Police, then concerned MP, MLA. So in democracy, so we have to do this. So congratulations again to Dr. Komal Chavan for doing this job. She met Maharashtra DGP, Mr. Rajni Seth, and discussed all the things. And now tomorrow, Dr. Komal and Dr. Mandrukar, they are going to meet IGP. And again, they invited to discuss these issues. With the galaxy of speakers like Dr. Gorak Mandrukar, Dr. Neeraj Nagpal, Dr. Sudesh, Dr. Girish Kumtekar, and all panelists, I think this will be a great event. I wish every success to Dr. Komal Chavan again for her endeavor in this running election of FOCSI as Vice President. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you. Thank you so much, sir. We are really honored to work under your leadership, and your guidance is the most valuable thing for the organization. Thank you for sharing your vision and your pearls of wisdom to the audience. And now I hand over to Dr. Monica.
Thank you, ma'am. Thank you so much for an association with Public Awareness Committee. Thank you, Rajendra sir, for giving us a free hand and trusting us with this work. We are sure that together we will always make a difference. It is my proud privilege to introduce Dr. Alka Kripalani Madam as the guest of honor for today's evening. She is the director and the head of the Department of Obstetrics and Gynecology and ART at Paras Hospital, Gurgaon. She has been the ex-professor and the head of the department at AIIMS, New Delhi, India. Her professional associations include President FOCSI, President Gynecological Endocrine Society of India, the Delhi Gynecological Endoscopy Society, and the Association of Obstetrician and Gynecologists in Delhi from the year 2013 to 2016. She has been the editor of Asian Journal of OBGY Practice from the year 1999 to 2017 and has been on the editorial board of 9 journals. She has received an overall of 47 awards, including the Padma Shri for Distinguished Service in Medicine by the President of India in the year 2015, the BC Roy National Teacher Award for the Eminent Medical Teacher in the year 2007. We are honored, ma'am.
Best, enough. Thank you. Thank you so much, Dr.
Thank you for accepting.
Thank you, Monica, for your kind words. And I must start with your president AMOX, Dr. Pardesi. I have so much of fixation for him. Actually, I'm watching him for decades. All my GACI conferences, he always used to be there. And when I was president, he organized such a lovely conference. And there was a big session going on. In those times in North, we were not so much bothered. PC, PNDT. And so many young girls were crying in the session that we are being harassed and our ultrasound machines are. And I really appreciate Dr. Pardesi, such a great, serene person who keeps on, motivating others and quietly working. Big leadership, lovely conferences he organizes, and congratulations for being president of AMOX. I have been attending and participating in AMOX quite often in the past, and wonderful attendances are there. In Maharashtra, your conferences are very well attended, and people are mostly inside the hall rather than outstanding. And I'm pretty sure in your webinar also, these topics are very, very pertinent. In the past, we were not bothered, let me honestly tell you, about the law. But now there is so much of, in interference of the law with doctors. We really fear. See what happened to surrogacy, what happened with these laws. And these POSCO is also a big issue because patients come, we work, and then later, you are caught in ugly situations. So I really appreciate, and I should not forget Komal. I was, introduced to Niranjan before Komal, but I can see the Komal is so bright, working so hard nowadays. Komal, I appreciate your hard work. And as Dr. Pardesi said that you are going to meet police people and all, this is the true work of any association worker, maybe Foxy, maybe AMOX, that we have to take, interest rather than being just academic lectures. We have to work for the association in these matters so that our members, get relief from harassment. And I think today it's going to be very, very valid points of discussion, this POSCO thing. And I should confess that I'm also not very well aware of laws. So it is important for seniors, juniors, youngsters, for everybody to listen to these webinars and be updated about the knowledge of the law, which we sadly are not taught in our medical practice. We have to in practice gather this information by these webinars and colleagues. And I wish you all the best. I'm sorry I don't know many names of MOX office bearers, but I can see Dr. Monica, Dr. Balhara. I think they are the very important workers, and really congratulate you people for great work. And I hope this webinar will be very useful for the practicing gynecologists. Academics nowadays, it's not difficult to gather information. These webinars are very, very important to update you and have hassle-free practice. Thank you for the invitation. And Pardesi, it's a mutual admiration committee with you. And Komal, I'm really appreciating your hard work. Thank you.
Thank you.
Thank you so much, ma'am. Thank you, ma'am, for your blessings, and your messages are very well taken. We definitely will work for the association and for our AMOX members. I would now hand over to Pratibha to please carry forward the academic session. Thank you, Pardesi sir, for being there always and for gracing this occasion.
Thank you all the esteemed guests for today, Dr. Alka Kiprani madam. Thank you all the esteemed guests for today, Dr. Alka Kiprani madam, Dr. Rajan Singh Pardesi sir. Now we move forward to our first session for today. I would like to call upon the chairpersons, Dr. Nalini Bagul madam, who is the director of Bagul Hospital at Nashik. Can I have a CV, please? Yes. Dr. Nalini Bagul is the director of Bagul Hospital at Nashik Fertility Center at Nashik. She has been the president of Nashik OBGYN Society 2019-2020. She has been the organizing chairperson of AMOX 2023, which we relished at Nashik recently. Organizing secretary of ARTCON 2019, organizing chairperson Star Nogs 2019, conducted hysteroscopy workshop in AMOX 2010, master in laparoscopy, master in reproductive medicine from London, and she has completed a fellowship in IVF from Brussels, Israel. I welcome you, Nalini, madam. The other chairperson for today is Dr. Kiranmai Devineni. She has finished her MD FICOG. She is a professor OBGY Society, OBGY from GM Vanaparthi. She is from Telangana, and she is a chairperson for FOXY No to Wow Committee 2025 to 2022 to 2025. She is a member of FOXY Youth Cell 2022 to 2025. She is a member coordinator for TOT and Faculty Dhira Initiative. She is a trainer of trainers, and she has received many awards, recipient of MS Signature Award and peer review for Jogi. Thank you so much. Thank you so much, Kiran madam.
Thank you so much.
I hand over the mic to the chairpersons to call upon the speaker for today and continue with the session. Thank you.
Yeah,
Yes.
thank you so much. Madam, would you like to introduce Dr. Nalini?
Yeah. Thank you very much, all of you, for attending AMOX 2023 in large numbers under the leadership of Dr. Padeshi sir in Nasik. It was whooping 2004 registrations were there. And let us see the introduction of, we have already done the introduction of Komal Chavan, but we'll repeat that she is the medical director of Chavan Maternity and Nursing Home, senior consultant DMB teacher, and unit chief of VN Desai Hospital, Mumbai. She is ex-honorary professor, Dr. BN
I think
Dr. Cooper Hospital, yeah. And she is basically contesting for the VP post. Already many of us have voted her, but if not, kindly do remember Dr. Komal. POSCO is the protection of the children from sexual offences. We are facing POSCO Act, especially registering cases with the police. Doctors and police are also confused how to get them registered. So thanks the efforts of Dr. Komal and Dr. Mandrupkar for creating awareness in police department. Let us hear pearls of wisdom from our vibrant Dr. Komal. Yeah.
Just to add her biodata, madam, I wish to add her biodata recently. For this POXO Act and police cases against doctors, that means 304 and 302, these columns means they are unnecessarily imposing 302 on doctors. And
Yes.
POXO Act specially, Dr. Mandrupkar and Dr. Komal Chavan, they made a draft, and Komal Chavan, in spite of her busy schedule in this election, she met with Director General of Police, and tomorrow also she is going to the delegation to IGP.
Okay. Yeah, great.
Yes,
Great.
yes.
We're looking forward, and all under the guidance. I think it is very, very neat, because I working even in Mumbai, we all have problems. It's not like the colleagues which are working at other levels. Every hospital, there are some of the other problems with coordination with the police staff and everything. So I think it is a very rightly thought by Dr. Pardesi that we need to represent, and these processes should be streamlined, because one case takes a lot of time. We get one POSCO case. I think my resident doctor is busy for 2 hours with that one case. So many references and so much to be done. So thank you so much, and I will start my presentation. And thank you, chairpersons. I think Dr. Nalini, you're a dear friend, and your conference which we attended was so wonderful. And we still have the memories of the AMOX Nasik. It was like a benchmark conference. And Kiran Mai, also a dear friend, and she is a chair of Violence Against Women Committee. And with Violence Against Women Committee, I think she really needs to look also regarding the POSCO and these violence cases which happen to our younger girls. So I think we have two right chairpersons, and I think their inputs and thought also would be more valuable, because I'm just going to throw a light and a technical difficulties in my talk, and how to go about that is a substance, that is the purpose of this talk. So POSCO and MTP. So when we talk about POSCO, we usually encounter very small girls. Usually they are less than 18 years of age. And sometimes even a 19-year just completed 19 comes with pregnancy. And then probably she has been sexually active when she was 18. So again, there is a dilemma, how to go about and all these. So when we have these girls between 12 to 14, definitely there is no dilemma because they become pregnant, but they cannot indulge in sexual act. That is what the law says. And these figures are very alarming. In United Nations, the pregnancies before the age of 18 are very high. And so in India also it is stopping that women are giving birth to the age under 18. And this can happen because of certain customs and norms. The representation which we gave, it also highlights that there are certain customs and norms which make their girls marry early. But the marriage becomes illegal. You cannot marry somebody before the age of 18. And even if they are into a consensual or a married relationship, still, as per the POSCO Act, it is not going to be legal. So this is the burden, and that is the reason they sometimes you don't come to the doctors. They end up into abortions. Almost 55% of these pregnancies. This is a 2019 data. And because they land up into abortions, we have a lot of complications. They are at risk of a lot of medical problems. So we really need to guide. When they come to one doctor, sometimes they run away, they get scared, and then they don't come back. And that is a reason they resort to all these unsafe practices. So we need to be really, really concerned. And I think the SDG goal also says that we really need to prevent the complications of pregnancy in adolescents, the complications related to maternal morbidity and mortality. They both are very important and it is part of our SDG goals. We really need to achieve that so that we keep our younger patient which come to us really healthy and risk-free. And we really need to look into the social factors also. In India, as I said, child marriage. This is something which is really, really rampant. The poverty, they really want the girls not to take education, get married. There is no sex education. Then there is a peer pressures also. Sometimes they're young girls, they elope with somebody. Many cases. In an emergency, when I was in Cooper, I think Cooper coming in the Jew area, we used to get around 8 to 10 cases of sexual assault or sexual abuse or even POSCO. Out of them, 2 to 3 are POSCO, and they used to actually be consensual, running away, and then they are caught by a police and brought by PC. So all these peer pressures to indulge in all this risk-related behavior, this is a very common thing which is happening, and the addictions, lack of support, familial support. But most important is exposure to sexual violence. And this sexual violence can be really in your known environment too. So it is so very important that we feel that the younger children are safe. You feel that this is a assured and a safe place for them, but it is not such so. And WHO also has reported that violence against women prevalence by 2018 notes that adolescents between 15 to 19 at 24% are estimated to have been subjected to physical or sexual violence from an intimate partner at least once in their lifetime. And almost 16% of the adolescent girls and the young age women, that is 15 to 24, have been subjected within the past 12 months. And really these figures are so alarming. And recently, just a couple of months ago, I had a small girl, 3-year-old girl. The mother used to keep near her partner, a very good friend, and the family and the child used to play there. And she complained of some bleeding and pain at the local site. And to my surprise, it was a tear and a small bleeding coming. And she really used to, she named that person, some uncle. So I think when you are not prepared, the person who is assaulting is somebody very near. So children are not safe and the child abuse is really, really very high. So these figures are alarming and we need to look at all these factors that how we go about. So coming to the POSCO Act, the subject we all know that is prevention of child against sexual abuse and sexual assaults. So now I'll go with a case scenario. It's a typical case scenario. She was a case scenario who came to our hospital. A 16-year-old girl was brought to a hospital by a police. She's actually fallen in love with a 22-year-old boy. and had started living with him. On finding his daughter missing, the father reported the matter to police station. When police caught them, brought them, the boy was arrested, registered a rape. So now it comes under POSCO, and that is the reason she was brought to the hospital along with father for examination. But on examination, because she was staying, she is now 10 weeks pregnant. So they said that yes, now she needs to be secluded. She was attached to a sheltered home, and then she came for a medical help. So what becomes the role of doctor is definitely to provide the medical treatment as well as the psychological support. We need to do certain references also to ensure that she is good medically fit for the procedure. And as per the hospital protocol, also we have a counselor center, we have a Dilasa center in our hospital. And everything was explained to her that yes, you are under the age of 18, so you cannot have a consensual relationship, and that is the reason your boyfriend has been arrested. But what came to a surprise was something that because the counselor said that because she was under the age of 18 and that is the reason she cannot stay and everything, she was literally scared, and she was given the chance that whether she wants to continue the pregnancy. Definitely nobody gives a chance, and abortion would be the safe option. But the girl's father was really enraged. He says that if you do an MTP, it is not good. I want to marry her, or I don't want to take treatment here. I want to take her to village. That was the thing. I want to just keep her in the village. I don't want her. She will again and again run away. And that was causing discrepancy because we needed her consent and the guardian's consent for MTP. So legality comes when the father was not was saying we don't want to do anything here. We don't want to get involved in this police case. We just want to go to our village. That was the thing. And because of the controversy, she was in a shelter home and it was a Catholic related, and they were also not quite keen on doing an MTP. But we were trying to counsel that definitely she's very small. She's 16 years and continuing the pregnancy definitely would be not good for her. And she's just 10 weeks, so we can definitely do MTP, and all that we try to counsel. So all these after counseling, we also recommended the child to be present to child welfare committee, and then with that committee we could convince the father so that he at the end agreed to give consent, because we really wanted the girl to undergo MTP, and then she went MTP as per the POSCO, because that is very, very important when we get such cases where we have to do MTP. The consent, taking the consent becomes the problem, and that is the reason most of the patient even don't do examination. They retrospectively they come with a Aadhaar card, or later on they come, they lie their age also, and that is where the doctor gets implicated, because everything by them is put in a different picture, and if it comes later on, then the doctor becomes a party to everything, and doctor has to face the consequences. So the idea of highlighting this was because we should not come into problem. We need to take certain references, and we need to keep inform the authorities as and when how the procedure is happening. So definitely the Ministry of Health and Family Welfare guidelines have said that a survivor is about 12 years. The consent is taken for examination and others. But the MTP Act doesn't mention the age of 12. MTP Act says that only to give consent at the age 18 years and above. So we require a guardian's consent as per our Form C of the MTP. So a guardian's consent is actually required. We really also need to take consent. The products of conception we have to send for DNA analysis. This also becomes very important, because if an MTP is done by a doctor without giving the evidence for examination, the doctor comes into problem. And definitely they will match with the partner or the boyfriend, and the arrest is going to happen. So this is all the consequences which we all are aware, and the doctor needs to always provide the right treatment. We need to provide it. We need to stick on. We cannot say that you go with the pregnancy or something. And forensic examination, the evidence, all the evidence, including the products of conception, because we're talking about MTP. But if she is not pregnant and if the act is very near, then you need to collect all the swabs and send it in a proper sealed manner to the forensic science laboratory. And the police has to coordinate all this. It doesn't happen only with doctor and the laboratory, but the police has an active role to play. And this is very, very important. So POSCO Act, we know, has come into force from 14th November, that is a Children's Day, and 2012. And since then, this act protects all our child. So it is applicable in whole of India except Jammu and Kashmir, and it is below the age of 18. And this is actually for the best interest of a child, because the act considers anybody who is below the age of 18 is a child, and they cannot give consent for sexual intercourse or cannot get even married. And anything, even if it is with consent, it comes under POSCO Act. And you need to inform, even if they pressurize, the relatives come. There are lot many stories. They'll come, they will try taking your time, and they'll try taking all this. They will give you some false certificates and other things. So all that happens because they have to just prove the age, being 18 or above 18. So, but informing and doing your duty becomes very, very important, because we are binded by the POSCO Act. And what includes in the POSCO Act is everything, that is penetrative sexual assault, aggravated penetrative sexual assault, aggravated sexual assault, even sexual harassment, and using child for pornographic purpose, trafficking of child for sexual purpose. Everything comes under POSCO Act. So it need not be only a sexual intercourse, but a sexual assault for pornography or trafficking of child, all comes under the POSCO Act. And if somebody is found guilty, they get a rigorous imprisonment for life and even a huge fine. So evidence, doctor's role is keeping the evidence good, because we don't want people to indulge into habitual such cases and something happening to our teenager girls and adolescent girls. So we need to document it very well, and that is the role of a doctor. We need to inform to the hospital authority, we need to inform the police, and need to keep our paperwork very, very good. That is the section 19 and 21 of the POSCO Act. They talk about the punishment and how we need to examine this patient. And is POSCO Act even valid even if she is married? Sometimes they elope and they get married. So even a married female, if she is below the age of 18, she comes under the POSCO Act. So we need to remember. And there is a special juvenile police unit and a child welfare committee where we need to inform all these matter. We need to inform the matter, and we need to keep the counseling committee also in check. So this is the Criminal Law Amendment Act of 2013 in section 357 of the Criminal Penal Code says that the public health practitioners are obligated to provide treatment. So we should always provide treatment. We cannot deny treatment or cannot shunt patient. And this will cause an imprisonment for a term which may extend to 1 year or fine. So healthcare professional needs to respond. And even if the relatives are saying that we will take them to village, yes, your duty first is to inform the police immediately at your center. Sometimes you tell them to do all the references, or you tell them to come back, or for something, some investigation, they may not come back, or from the hospital only, they will just run away. So what we do when we have such patients coming in, we try to keep like a safe corridor. We try to tell our staff, alert our staff from the first floor to the ground floor, wherever she's going, so that the patient should not run away. It needs to be documented. We need to collect the evidence. We need to fill the forms of the sexual, the medical forms, which as per the MO, Ministry of Health and Family Welfare, we have our forms. So we need to fill all the forms. So all these, that is sexual assault forensic evidence kit, that is safe kit protocol, which is there in every hospital in the OPD and the ward. We collect all the evidence. We need to take the consent. We need to put our examination findings, everything. And the first contact, even psychological support. We have a Dilasa center where we send them. We try to find out the detailed history, because they sometimes don't open up to the doctors. And there is an underlying factor, when they are brought, probably the parents look very shocked in front of you, what is this and all that, and they are very scared. But probably they must have gone to 2 doctors and they don't open, or somebody known person. Sometimes even we get that it's an incest, and the child is being harassed in the house itself. So after doing the procedure, again, you can't send the person to the same place. That also becomes very important. So you need to have this counseling support and a proper validation, everything, whatever you do, documentation of all the investigation, everything. Also, it's not very important to do an age estimation. Earlier, we used to do many age estimation by forensic. if a patient is carrying a Aadhaar card and it is a proper from all sources, if it is or a school living certificate, I think it considers to be a good document for age proof. And if by that document she is minor, then definitely it comes under POSCO Act. You need not hesitate saying that this is wrong or something, or we get a age estimation by a orthopedic or a dental. So that is all is not needed as per the act. And definitely we need to also keep the shelter home, because sometimes you may not send her in the same area where the abuse is happening. So that is very, very important as per the Criminal Law Amendment Act. So this is how we will do. We will take a detailed history and a consent before examination. Above the age of 12, even a patient's consent is required. You will do an MLC, you will do examination, you will fill a POSCO form, we do a reference. This is the age, what I spoke, radiological, not that required, but if there is no Aadhaar or birth certificate, then definitely a radiological age estimation is required. We need to counsel before you do MTP. The consent of the guardian must hear in counseling. Patient needs to be admitted here, because if you have this patient which I spoke is a first trimester, so if it's a first trimester patient, you will do you cannot give your medical methods, you will have to do a surgical method. You will need to collect the sample in the specified bulb which are brought by the forensic lab. A PC will get it. So we tell them to get all these bulbs before we start the procedure. We collect the products of conception sample. Also, the patient's blood is sent for the DNA analysis. They are sealed in front of you, taped, sealed, and they are put in a proper envelopes which are provided with the form. And all the evidence are then labeled with the AMO and doctor signature, and they're handed over to the police. And they go very safely to the forensic lab for analysis. And if the patient becomes a second trimester patient, then we do a second trimester termination of pregnancy, and here we need to send the DNA analysis that either the thigh bone or the scapula or large part, we have to cut it and send it again in those containers. And we need to seal it the same way as we do for the first trimester, and it needs to be sent. And then the police will definitely check the DNA analysis with whatever suspects they have got. If you do not collect all these, because what happens is that then the doctor is held responsible for tampering of the evidence, because this evidence becomes the very vital for conviction of a person who is accused. So if you have not, like probably if you have a doubt of some patient or something, so always try to take the Aadhaar card and check it for your safety, and then do the MTP of these younger looking patients, because tomorrow they may turn to be minor, and if they have given an age and she turns out to be a minor, and then retrospectively also many doctors have received a notice from the court and from police that you have tampered with the evidence, or probably you have done some foul play, and these doctors are harassed later. So all these documentation, whenever we get a POSCO pregnancy, we need to document it. We need to do MTP as per the rules. We really need to follow the POSCO Act also and the MTP Act also. So that becomes very vital and important. And this is the guidelines and protocol. This is by the Ministry of Health and Family Welfare. So this is available. I had shared earlier in the MOX group also, and I will share with everybody. And this is how we take the consent, the sign, the thumb impression, or of the sign of the patient before we proceed for investigation. And this isn't triplicate. Like one remains in your file in the ward wherever you keep in the booklet. One goes with the patient, one goes with the police, and one goes to the forensic lab when you're sending the evidence. So it goes in everywhere. It comes in a carbon sheet. So it's a whole booklet which is required for every patient, and we need to fill for every case of POSCO. Whether you're doing MTP or no, if there is a POSCO patient brought to you, you will collect evidences, you will collect the DNA. If it's a recent act, you need to collect the DNA, the clothes of the patient, everything needs to be packed and sent. Then the DNA collection, the combing of the hair, then the oral scans, the nail clippings, and the perineal areas. If there are any injuries, everything is there. It's a full comprehensive compact form. Everything is, you will not miss collecting anything if you follow the medico-legal examination of sexual violence. And this is not for POSCO, but for all cases of sexual violence, you need to follow these protocols. So I will share this form, and with that note, I will end my talk. Thank you all for your patient hearing. And I know everybody has voted by now, but if not, please do vote. The voting lines are still on till 10, and every vote is going to make a difference. So please, I think nobody should be missed. This election is breaking all records with record number of voting. And one vote for me definitely will make a difference, and I'll be always there at your service to work for you. Thank you so much for your patient hearing.
Thank you, Dr. Komal. Wonderful and very informative, very passionate as always. Your energy levels, enthusiasm, and everything we all know. I think you will definitely go ahead and serve in the capacity of Vice President. We are looking forward to your wonderful tenure again. And
Thank
coming to the POXO, as you said, so much of that we need to know. Generally we tend to go for the clinical aspects, and then we generally keep away from the medical legal aspects. As you have said, in the No to Violence Against Women committee, even before the committee was formed, in the Dira Obigain module, one of the module is examination of the sexual assault victim. And as you have shown the ministry guidelines, they are like the torchlight for all of us. If you follow those guidelines, you will not be at fault. And also, if you remember, the Supreme Court Chief Justice commenting very badly on the doctors still doing two-finger test and all. So all those very clearly the guidelines mention in that. We have made a module out of those guidelines. We have done a POXO webinar also, and this conflation between MTP and POXO and young patients. We have, all of us have lot of cases to share. Recently, we have had a young, very teenage girl with 7 grams, 28 weeks of pregnancy, and no kind of amount of counseling could prevent the parents from taking her underground. They roamed all around the district, all the government hospitals. They were not willing for continuation of pregnancy or going to the court, or no action, nothing. They just wanted termination at 7 grams. They were not even willing for blood transfusion. Really very sad that what happened to that patient, because everybody refused. And everybody was, and she was with the Saki Center, the one-stop crisis center. So the Saki Center was there, we were there, everybody was there to help, but still the parents took her away. So such is this thing. And again, and we have to have the teen girl in view, also our own safety, as you have told. It's a tight rope to walk, balance between all these medical legal acts. Thank you so
I know
much.
it is really like all these, the parents, they try to come up with different aspects or they try to complicate our simple management,
Yes.
That is the reason. So I think
absolutely
this is definitely there, and I think you're doing very good work with the Violence Against Women Committee, and definitely we are looking forward to work.
Thank you, Dr. Komal. Best wishes to you. Thank you so much for giving me this opportunity to chair your session, and my respects to Pardesi sir and Alka madam. Thank you for that.
Thank you, Kiran ma'am, and thank you, Nalini ma'am, for chairing this session. Thank you, Komal ma'am. Ma'am, but there was one thing that we wanted to highlight is the age of marriage in rural Maharashtra is still 15-16, ma'am. When we have a lot of patients in our OPD who come at the age of 15-16 and are having a second issue, ma'am.
That is the reason you need to report, because what happens is that if we don't report these marriages, we come into problem. So whenever we get a patient who is underage, even though is married, it still comes under the POSCO Act.
No, my question is, Dr. Komal, in the case sheet on the front page is where we see generally age of an antenatal case, married antenatal young patient. Generally, they are smart enough to put their age as 18 and 2019, but we have this KCR kit which we give after delivery. There comes the problem, disparity between what the age they generally say and what her original age is, that is 16, 17. So there comes the problem, there comes the dilemma. As Monica said, really, do we report all these married young girls?
Yes. Now, what is the BMC, that is the the Corporation of Mumbai, what they have done, it is mandatory in all the public hospital. Without Aadhaar card, you cannot AMC register. So a patient, there are so many patients who come to us, they say that wo gaon se aayi hai, Aadhaar card is not there. She can come to OPD for checkup, but
not
AMC registration is not given to them, the paper without Aadhaar card. So it has become very mandatory, and that is the reason people become aware. And that, I think that has made a change. when we catch these patients very fast. No, so many, one day we'll get so many, all these patients because they try
You
to
are
hide
reporting all these cases, even with marriage.
marriage.
Ma'am, we have to.
Yes, we have to.
You are reporting all the cases.
Yes, ma'am. Ma'am, in Sholapur, what we have done is because most of us, when we go for reporting, the police station will say this is not in our headache, this is the rural parts, we'll have to go to the rural police station.
Agreed.
So we've asked them to give us an online support where we could just email them and it would take our complaints, or give us one point of contact where all these patient cases could be reported. So we are working on that one.
It's a really complicated situation. The other day we had to convince our administration itself that we have to report such case. Hospital administration, apart from OB-GYN department, also sometimes.
How many people we are going to sit and convince? You know,
Yeah.
it's not our. They should be
Our job, basically. See, we are given the onus of reporting. The police
everything.
don't give
Doing the clinical
immediate
management.
response.
Yes.
Administration doesn't understand.
May I suggest one thing? I'm sorry for intervening.
Yes, sir.
But
Yes,
the
sir.
thing- Yes.
We want-
Well, the thing I will suggest to you, the police decline to take your report or your application of information. You just do one thing. If you are in the city, you register, send it the application, our information report directly to the commissioner with RPID or a speed post. If you are in the rural area, send it to the superintendent of police.
Or
They have to
email
take
also
action.
should,
They
email
have to
also
take
should
action.
help.
Some information has to reach them somehow.
Yes,
If
somehow.
the police station fails to accept, just send it by RPID to commissioner or superintendent of police. Your duty is over. That we have
happens,
practiced in
local
Solapur.
police stations.
With 2 consultants, I have practiced this and it has worked wonders with them.
Oh.
And email also helps, and it will be evident that they have not replied or responded to your email. That is one thing. And
Just
Dr.
send
Kiran
by RPID, that's it.
Yes,
Dr.
I think
Kiran and Dr. Komal, it is not only the general public, it is even among the doctors, the gynecs only, about this awareness is not there. And talk like this will help them to sensitize, like we have to report. That thing itself is not there. And not only the pregnancy, it is the first sexual act at 18. That itself they don't know.
Yeah, actually, the case that I have told Dr. Komal, the young girl with advanced pregnancy, one of our assistants outside was she had so much of sympathy for that young girl. We had to convince her, you cannot just abort or take up the case just like that without informing the police and all. So as Rekha said, it is our own people still need awareness.
Yes,
And non-gynec's though, I don't think I saw they were not aware. Even our RMOs were not very much aware.
They're not aware of neither the POXO Act nor that it is not the pregnancy, it is the first sexual act at the age of 18. That
Yes.
also is not there. And third thing is this Aadhaar card is, yes, agreed that the age and all that, but fake Aadhaar card. So we may have to be very suspicious about the age of that girl. Like somewhere around 21 to 22 is difficult to sometimes recognize and exact age, if the Aadhaar card is not the right one.
at least tomorrow when we have the Aadhaar card documented, at least we have documented it and we become safe. Because we
Yes,
have asked for Aadhaar card. And also to our rescue, we have a Dilasa center in adjacent to our OPD. And I think they try to go into a lot of the social and other aspects for POSCO and other cases. So that guidance we get it. That is the reason we report many cases. But
Yes.
what happens is that if you don't have all these people coordinating at the same time, you may miss out. I agree, definitely. It is
Yes.
not possible for a doctor to keep track of all these things. So we need
Maybe we need awareness webinars in
Yes,
the non-gynec and administrator kind of
about all these acts.
IMAs or somewhere where maybe we have to reach out.
And wish that our work becomes easier around this running behind the police act. As Dr. Monica said, this is not in our police station, that, this and all, so that we ultimately concentrate on our niche job.
Legal, yeah.
What we are supposed to do. Thank you.
Over to you, Pratibha, now.
Gorak wants to speak, and I think Dr. Ashok Shukla also is here. So I think Dr. Gorak, you can go first.
Yes, good evening all of you. It was very nice lecture. I want to give the suggestion that in your local societies, you should arrange the meeting with your police department as well as with the child welfare development societies. And once you make a good rapport with them, then only this problem is going to solve. Because this law is in place since 2012. And still, as one madam was saying, their administration was not knowing that. So that is a dangerous thing. And the information to the police is not only to be given by the doctor, but anyone who comes to know about it has to give the information. It is not only the doctor. So that's very important thing. So we are taking these many things as a casually, and one should not. In Maharashtra, our AMOG president, Dr. Pardeshi sir, has given a letter. And right now I'm in that vehicle only. I'm going to that meeting tomorrow. And even Dr. Komal madam will also be there. So ideally we should have make a rapport with the police, with the child society, and then this problem will solve. Otherwise,
That's a good idea, sir. Maybe we can have a meeting and academic and discussion kind of with administrators, the police, and the child welfare department together at the hospital level.
the problem will be sorted out. You have to write one SOP. Yes, over to you.
Dr. Gorak, one madam nahi. You know me, Rekha Rajendra Kumar.
I'm sorry. No, actually, now I was listening only. I was sitting in the car. I'm so sorry, Dr. Rekha.
मला माहिती आहे.
Can I add something?
Yes, Dr. Ashok Shukla.
Yeah. Komal, good that you are meeting the police officials regarding this because there's a lot of harassment. What the problem doctors are facing is, even if sometimes they go on the next day to inform the police officials are very smart. They'll make you co-accused instead of witness. See, basically, when we are informing the police, we are in fact the witness of sexual assault. Because we detected pregnancy and found out that she has been, because the government rule says below 18, if she is consensually sexually active, still it's a rape. She cannot give a consent for sexual activity. So we repeatedly are requesting police to please don't make doctor co-accused, make them witness. The other problem is today, like you are in a government hospital like KM Sayan, and you see a young girl, 16-year-old, she comes from Guwahati or she comes from Haryana. And then when this matter starts, then you get letter from Haryana, because then she goes back to her hometown. She had come to Mumbai to deliver. And now from here, the doctor has to travel there. Becomes a big problem because you were the first people who took the history, which is going to justify whether what history she told when she came to the hospital. So all those things are there. Third part, the consensual part, a lot of court judgments are also coming that they are slightly lenient between 16 to 18 for consensual sexual act. I feel all government hospitals should create a database where they have that age group as well as patient complaining about harassment. See, when we go to the police and tell, oh, they feel that you are doing MTP, you are earning also, you are taking care for the private people. But when the patients complain that they are suffering because of all these paperwork, when they are 17-year-old married, whatever is, has any police arrested a 17-year-old couple and kept behind bar because they have married below 18? They know the act. Below 18, they are not supposed to, but they know that gray zone. They don't do. But they will definitely arrest the doctor if they do inform.
Right.
So why this disparity? So when the patients complain, when the politicians, these patients go to the corporators and municipal council, you created the law because of which we are suffering and we have to pay to the police. Please amend. Then these things will work, and then after a few years, maybe we might get a window or some amendment or some power to the doctor to decide or to judge, on the doctor-patient. Otherwise, harassment will go on and patients will refuse, doctors will refuse, and patient will end up with illegal abortion.
Once the marriage has happened, the lawmakers, police, everybody know. And once she becomes pregnant and comes to us, and again the owners to report that.
Madam, the problem is the POXO Act is very clear. Below 18, they don't care, married, unmarried. Because in India,
Yes,
even
sir,
Marriage Registration Act, even being mandatory, how many people have got married and really have got it registered in the court? So a lot of times people will come and tell false, we are married. They wouldn't have registered and they will try to cover. That's the reason government below 18, they have given a blanket. She doesn't have power only to give consent for sexual life irrespective of marriage. Now these patients, if they complain, as already people told, there are a lot of communities at 15, 16, they get married. They have to go and complain. Then only things will work.
I think this discussion can go on and on.
Yeah.
Thank you, Dr. Komal. I have to leave. Some other meeting is there. Thank you so much.
Yes, thank
So
you.
thank you, Dr. Komal and Monica, for the excellent session. Yeah, very informative and to the point. Komal.
I think there is little disturbance in the.
Sorry.
Pratibha?
Monica, can we go to
Pratibha?
the next section? Yeah. Yes,
Yes.
I think we can.
Introduce the
This
moderator
discussion
and the
can go on
panelists.
and on. It's a never-ending topic. I think we can move on to the second session now. The second session is panel discussion on ART law and possible litigation. The moderators for today is Dr. Swarupa Iyer, madam, and Dr. Rekha Rajendra, madam. Dr. Rekha Ranjit, madam, has received many awards and achievements. She has received first rank at the MD University, 7th in the Bangalore University. The various positions held is practicing gynecologist for the past 31 years, president-elect of BSOG 2023-24, invited faculty in more than 700 state, national, and international conferences. She's a chairperson of Ethics and Medical Legal Committee, Kasoga 2023-25. She has many papers and publications to her credit. I welcome you, Rekha, madam. The other moderator for today is Dr. Swarupa Iyer, madam. She is a MD, DGU, and LLB. She is a consultant obstetrician gynecologist and a fertility specialist, medical legal advisor, and a secretary of dogs. Member of Medical Legal Committee, FOXY, peer reviewer for Journal of OBGY, Journal of OBGY of India, and practicing since the last 23 years at Bapat Nursing Home, Curio Hospital, Jupiter Hospital, and honorary laparoscopic surgeon at Kutum Niyojan Kalyan Kendra. I welcome you, Swarupa Iyer, madam.
Thank you.
We have the expert for today, Dr. Ashok Shukla, sir. He is DGO, DFP, LLB, and LLM, president of AMC Mumbai, convener at AMC NOAH, owner of Sai Ashirwad Maternity Nursing Home, and committee member of AFG, chairperson IMA MS Medical Legal Cell, and past committee member of MOGS, trustee of Bhayandar Medical Association. I welcome you, Ashok Shukla, sir. We have panelists for today, Dr. Girish Kumtekar, sir, a very renowned person of SOGS, consulting obstetrician gynecologist, infertility specialist, medical legal consultant, practicing since the last 35 years, and doing infertility practice since the last 15 years, medical legal practice since the last 22 years. He is a member of Medical Legal and Ethical Committee, FOXY, past member of Medical Legal Committee, IMA State Branch, and faculty at many state and national conferences, and he has been giving us guidance and lectures at SOGS as well as various conferences of FOXY and AMOGS. I welcome you, sir. Dr. Sudesh Joshi, sir, he is also very well known to our SOGS society. He is a senior obstetrician medical legal consultant working since the past 25 years, a roaring obstetrician of Pandharpur and a well-known medical legal consultant, a member of NIMC PCPNDT FOXY, past president of Pandharpur OBGY Society, and member of EMLC FOXY, a zonal coordinator of AMOGS. I welcome you, Sudesh, sir. Dr. Suyoga Panath, she's a consultant obstetrician gynecologist, fellowship in advanced fertility, recipient of MS Signature International Award, Shailaja Chaudhary Award, and late Mrs. Tripti Umranikar Award for standing first in the university. She has worked at government hospital for the past 12 years, and she's member of Ethics and Medical Legal Committee, FOXY 2020-24, member of PCPNDT Cell for 3 years, and she has given various talks at national and international levels. Special interest in the mission Beti Bachao. I welcome Dr. Gorak Mandrupkar, sir, who is a consultant, reproductive medicine, MCHS, director of Angel IVF Clinic, Pune, postgraduate in clinical research and medical legal systems. He is a member, Task Force National Policy on PPH and Government of India, invented Justosis score, and is now doing the zero eclampsia thing. He has published 4 books, 9 publications, and more than 500 lectures. Developed medical Android apps for HDP Justosis score on prediction of HDP and Cross 11 for correction of anemia. I welcome you, Gorak, sir. But last but not the least, panelist for today is Dr. Shitabdi Dey. She has finished her MS DNB Fellowship in Reproductive Medicine, consultant in Nova IVF, and convener of PAC-FOXY.
Good evening,
Dr.
all.
Raghavendra Prasad. He is the Director of Infertility and Feto-Maternal Unit at Sunrise Hospital, Kanhangad, Executive Director in ARMC IVF, Mangalore. I welcome you, Dr. Raghavendra. I hand over the mic to the moderators to conduct the panel.
Yeah, thank you, Dr. Pratibha. Just allow me to share my screen so that.
Thank you, Dr. Pratibha and Dr. Monica. Thank you, Dr. Komal Chavan, for the opportunity, and Dr. Swarupa for being a co-moderator, also the panelists.
So it is seen, right?
Yes, yes.
My screen is seen?
Yes, yes.
Yes, ma'am.
Right. So, thank you, Dr. Komal Chavan and AMOGS, the whole organizing team, for giving us this opportunity. I think ART law has been discussed quite a few times now. So this time what we have done is we are just going to, like after the application of this act, the practical difficulties that all the gynecologists are facing, we will be discussing that with Dr. Rekha as my co-moderator. And we will have little crisp discussion on this topic, I hope. So thank you, Dr. Ashok Shukla, for joining us as expert, and all my esteemed panelists for being here today to have good deliberations on this topic. So when this law first came into action, we were like, something like this. So many people giving so many things. There were ICS before, and it was turned into kind of, some part of it was incorporated into the law, and we didn't know where things are going. Slowly, the lot many changes came. There were amendments, and there were lot many changes done through RTI. So we will be taking cognizance of all that, and my panelists will be making us more wiser. So actually, this act came. It covers everything, including fertility preservation. The main aims and objectives of this act was to basically discipline various ART activities. In the bracket, it can be read as those errand IVF clinics which were running and doing lot many illegal things. But जैसे होता है बुरे के साथ अच्छा भी punish होता है, तो there are many who are not doing anything are also going to get kind of streamlined because of this. To form national registry, national board, state board, and various other authorities which are in place now, to provide for the registration process of level 1 clinic, 2 clinic, and ART bank, and define their duties. These were the main aims and objectives of the act. Now, my question to the panelists is, there is a gynecologist who is just recently passed, Dr. A. He is passed out 2 years back, and now she decides to have to start with the infertility practice. So we'll go one by one. Actually, I'm not able to see the panelists. I think my view is. Anyone can take this question. Like, what is the first thing she needs to do? Dr. Girish, we can start from you. I can see you.
Yes, I can start with this.
Yeah.
As you said, a new gynecologist, very enthusiastic, doesn't want to practice obstetrics as everybody today wants, doesn't want to operate obstetrics, glamorous field of infertility, laparoscopy, and all this thing, fetal medicine. Anyway, that apart, but a very young, enthusiastic gynecologist when she wants to start fertility practice. Well, she can very well start, because fertility practice, infertility treatment is incorporated in her curriculum. There's no question about it. At what level she can start? Well, she can start up to level 1. If she's doing only consulting and stimulating and all these things, it's okay. But if she wants to go do something more than just stimulating and timed intercourse and all these things, she will need to register first with the ART under the ART Act. And then at a level 1, she can practice only up to semen processing, ovulation induction, and IUI. That is what she can practice as a new gynecologist.
Okay, sir. So now Dr. Gorak.
Right, as sir has rightly said, if she wants to infertility practice, again, we have to know whether she wants to do till level 1 or till level 2.
We'll come to that, sir. We are coming to that. So I'm that new gynecologist and I right now want to do only level 1 practice. Or rather, I don't even want to do level 1. I just want to do stimulation and I don't want to do IUI. What am I supposed to do?
Well, that you can do with you don't have to register for that. That is a part of the treatment, day-to-day treatment.
Yes, but can I stimulate my patients with gonadotropins?
No.
No. Why not? No. It's not written in the act anywhere.
It comes under the advanced treatment of infertility.
Not at all. Not at all.
No.
For the resistant patient, you can stimulate with gonadotropins. Why not?
Actually,
yeah.
Yes. Sorry to interrupt. Yes.
Dr. Rekha, you.
Yeah, very sorry to interrupt. It is Dr. Girish and Dr. Swarupa. What I have understood regarding this is, as Dr. Swarupa said, you can stimulate the patient. You can even give the gonadotropins.
Yes.
And that is okay. But if the clause is, if you have to handle the gametes outside the body, this is what is level 1 and beyond.
Correct.
And
so
if you are not outside the body, it is not under the purview of your registration.
So handling the gamete starts with doing IUI. When you are doing only stimulation, there is no handling of that.
Yes.
But still, I would have a reservation about gonadotropin stimulation, because you must be then capable of handling the OHSS syndrome and all these things, and you must be able to be competent enough for that. Of course, registration will not be required for that. I agree.
Yes. So the message that I wanted to give it here, there is ambiguity regarding using of gonadotropins, and many gynecologists feel or fear that they have to register themselves as a level 1 clinic, but it is not so. Unless you want to process semen sample at your own hospital, registration is not required. Okay. So,
but again, there is some confusion among us only.
Exactly, madam. So we are only creating confusion. So let's clear it that even if you want to stimulate, as but Dr. Girish rightly said, you should manage the patient in case of any adverse effects. So stimulation with gonadotropin can be done without registration once you have a qualification of MD or MS gynecologist.
Perfect.
Okay. Going to the next. So now we know that for registration, we need to go on this portal and register your clinic. So there are clinics divided into level 1 and level 2. These are the preliminary work that can be done in 1 and 2. So basically level 2 is everything else than only IUI. So retrieval, handling of oocytes, fertilization, ICSI, everything. So my question to panelists is, Rekha madam, can you take this?
Yeah. Whom shall I ask? Dr. Shatabdi?
Yes, ma'am. Good evening, ma'am.
Yeah, good evening. Hi, Shatabdi. My question to you is, we are talking about the level 1 now. In this question is, what are the basic staff requirement for your registration? Also, what is the equipment, what are the minimum equipments required for the level 1 registration, level 1 ART clinic registration?
Right, ma'am. Good evening to everyone. I have just switched off my video, ma'am. There is some network issue, so my audio will be on.
That's fine.
Yes, ma'am. Yeah, for level 1 clinic, as we just discussed, the minimal mandatory person is a gynecologist, of course, with MD or a MS qualification. In the beginning, it was mentioned that a counselor should be there, but now with the further amendments, the clause of a counselor to be there is not compulsory anymore. So a gynecologist is the only one. And also embryologist is a query because then it's not mentioned in the act anywhere that a embryologist should be there, but a level 1 clinic can do an IUI. So that ways, a gynecologist who will be running a level 1 clinic has to know semen preparation and should know the semen preparation and the basic things to be done for IUI. If he or she knows that, they can go ahead with having a level 1 clinic, and one gynecologist with an MD or MS qualification is sufficient to run a level 1 clinic. And as far as the equipment,
that was perfect. That's why basically I had put this slide. The counselor and embryologist is in a lighter because these things are not required now. So my question, you have already cleared, that is gynecologist supposed to process the semen sample on their own. So that is what is required of that gynecologist, right? Because the act says you can't transfer gametes, so I can't get it processed at somewhere else and then bring the sample to my place and then inseminate. Am I right?
All right.
Yes, ma'am.
So far as the letter and spirit of the act is considered, but I will put a question for the benefit of audience, madam. Suppose I employ a technician and I get done the IUI under my supervision. Will it be all right?
If you are doing it in your own premises, it is allowed, sir.
Perfect.
Yes.
Perfect. That's what I wanted to point.
One more question. One more question I had, because when you said you have to handle the gametes outside, where does semen analysis stand in this point of view?
Handling the gametes outside the body.
Semen analysis analysis comes in the diagnostic procedures. It doesn't come for the fertility procedures. So that is allowed.
Laboratory part of the.
Because in some of the clinics were even getting their sperm washing done at pathology lab. So these were the practices before. So that all is now, it has to be stopped.
I get sir's question. Means semen preparation, he wants to point out whether semen preparation is gamete handling. I would not agree with that, because gamete handling with a single gamete is to be handled, and that comes under level 2 because you are handling single sperm and all that. But when you are processing semen, I don't think it comes under gamete handling. That's why it is included in level 1.
Gamete handling for the treatment purpose, we mean.
Sir, sperm washing also comes under gamete handling, and that's why you need a registration. Though it comes in level 1.
Yes.
So it is considered as gamete handling. But what Dr. Raghavendra asked about semen analysis, that being a diagnostic procedure, it can be done by pathologists without registration, because it doesn't come under fertility process or fertility procedure. So the message over here is a gynecologist either can employ somebody, either embryologist or, as Dr. Giri said, technician, who can who is well versed with the techniques of sperm washing. But the crux of the matter is you have to get it done in your own clinic or your own space. Okay. Now my corollary to this is, Shatabdi, suppose I don't have access to embryologist, or I don't have access to any technician. So can I send this patient to a center which is registered, and they prepare the sample over there, and I go and inseminate because it is my patient? Is it possible?
I think over here, if I'm affiliated to the center that I want to do an IUI with, I can do it, ma'am. But I have to be affiliated with that center.
Correct. So the next thing in this is, if a gynecologist wants to go at the center and get the insemination done for a patient, his or her patient, that particular gynecologist needs to get affiliated to that center which is registered under National Registry. I hope this message is very clear. Now coming to requirement for level 2 clinic, who wants to take this?
And any registration is given to the level 1 or level 2. The registration is given in the name of the center, and then those who are affiliated will come there.
Yes, ma'am.
Am I right?
Yes.
Yes, ma'am. Absolutely. Yeah.
It is a center that is registered.
Yes, like PCP and
you can change, add, delete personnel working under. No
like PCP and DT.
Yeah.
Yes,
Dr.
madam.
Swarupa, she didn't answer that equipment part.
Yes, ma'am. For the level 1 clinic, the minimal equipments required would be, earlier it was a bigger list, but now it says a centrifuge machine, a microscope, and a refrigerator, ma'am. These three are the minimal things required for a level 1 clinic.
Correct. Yeah. Yeah, Dr. Swarupa, you can proceed. We can't hear your voice, Dr. Swarupa. I think you're talking. No, we can't hear you. Anybody can answer. Dr. Suyoga, do you mind answering this question? We're talking about the mandatory staff for level 2 clinic.
The gynecologist who has completed 100 pickups under supervision. She should be, he or she should be a master's only. Diploma degrees is not being accepted as qualification for as a staff for the IVF. Can you hear me?
Yes, yes.
Yes, yes. Yes, yes, sir.
Yeah. And embryologist, a person who is qualified with the basic degree, can be a microbiology PhD or at least has done a 2 years course in embryology. If it's a person who has undergone biotechnology, she should have had 4 years of work experience in a qualified IVF unit before calling herself an embryologist.
Dr. Gorak wants to add something.
Yes.
I do not want to add, I want to delete something, because there is nothing written in the law that the person has to be MD or MS. He has to be a gynecologist. That is very clear. Number 2, the requirement as per the law and as per the regulations which came on 9 June of 2022, it says that minimum 50 pickups should be done.
50, that's correct, 50.
Yes, yes.
50 pickups.
And if the person who is already working as a IVF consultant before the establishment of the law, then the person should have completed at least 2 years of his practice in infertility, minimum 50 pickups, that is mandatory.
And it says postgraduate degree, doesn't specify it as MS or MD.
No,
Yeah.
because when the
It is
registration was when the registration investigation, when the committee came for inquiry to Kerala, inspection to Kerala, they were refusing all diplomas. That's the reason why I said, because they gave us a format stating that diplomas are not accepted.
Problem is the newcomers who have taken this reproductive fellowship in reproductive medicine, they also don't have experience of 50 pickups. I mean, I have spoken to so many people. They said, madam, we don't get hands-on 50 patients. You get at the most 5 to 10. So it is basically that 3 years course. 3 years course in reproductive medicine. That is what is given in the last part.
See, I will make 3 distinct ideas about it. Either 50 pickups experience or 3 years experience under somebody who is working in the infertility. Or last is postgraduate qualification or fellowship in endocrine in infertility practice. These are 3 distinct qualifications.
These 3 are all or they are not and.
One independent of another.
Yes, one is. There are 3 distinct qualifications.
No. Please understand, sir, the or is written only for FNB reproductive medicine, but rest all are and.
No, sir. Dr. Ashok, can we have your expert opinion on this?
Ashok has left.
He has left.
Ashok has left, but it is nothing like that. It is very clear-cut written in the law that a postgraduate qualification plus 3-year experience and 50 pickups. It is for existing IVF consultant, and when it is new person, then 3-year 50 pickup and fellowship.
Sir, those existing clinics, they don't have these 3 years experience of fellowship or this. They have done 50 pickups. So it is or only.
3 years and 50 pickups.
Okay, we will go through that. We will see that.
I don't think so. I disagree. Anyway, we'll take the next question, madam.
Yeah, you can take, Sarupa, no problem.
Yeah. So we are one clinic only. So like suppose I am running a level 1 clinic. Can I stimulate my patient and send to level 2 for pickup? I think answer is, we have discussed so much. Answer is yes. Because if you can stimulate, you can always stimulate and send the patient.
Yes.
100% anything.
Correct. So we move forward. So this is the requirement of the machinery. Madam, you want to discuss anything on this? Because that is very clear cut, I think. Level 1, level 2 and ART bank.
Level 1, Dr. Day has already explained. Level 2, we know this is only about the equipments we have put here. This is all quite self-explanatory. If anybody wants to add anything about this, they can add. I think you have included everything here.
Yes.
So machine, anesthesia, everything's per the entire equipment of the IVF OT and the embryology lab. That is what we mean here. Two together, one side by side with another. Incubator 2, yes. It can be any trilaminar and carbon dioxide and that combination, that would be fine. And all that. And ART bank, all this. Anybody wants to add anything, they can add. Otherwise, it is self-explanatory.
Yes, ma'am. Self-explanatory, yes. Yeah.
Yes.
So my question to all the panelists is, we are going through and making so much of hue and cry about new ART Act, which is like, little tough. It is restrictive. So what has changed for ART clinics which are practicing only self-gamete cycles? Like they are not interested in suppose in donor cycle. Has this act changed much for the people?
Yes, it has a lot of changes. It is a restrictions on what to use, where to use, when to use.
Self-gametes.
Self-gamete is, that's where the record keeping is very important.
Age, ma'am. Age was not earlier specified. No, now we have the upper age limit for the self-gamete cycles.
Yes, but in which way the self-gamete is around 50. हम लोग 50 के ऊपर कहाँ वैसे भी
वो भी है.
Hey, madam, the common problem which we get is wife will be around 42, husband will be around 58.
It is a combined 90 years age. That is what matters, no?
Yeah, but wife is for 49
combined
and husband
90
is
is for the
59.
adoption, no, ma'am. Combined
Not
90 is for the adoption.
Not for
this. Self for doesn't matter.
Combined 90 is for the adoption.
Age limits between 21 to 55. So age, I understand, but see, there will be very few patients you will be getting beyond 55 for stimulation. So as far as my point here was, self-gamete cycle when an ART clinic is practicing, there is no much problems for them. Only thing is, as Dr. Girish very rightly said, there is very high level of record keeping.
Right.
But I feel it is good so that we are creating our own data and we have our own studies which we can, publish later on.
Dr. Swarupa, I would like to interrupt. Sorry for that. If you want to talk and finish, and then I can talk too. No problem. But I have to add something.
Madam, you can tell now.
Regarding, before you shift to the next slide, I wanted opinion of all of you, including Dr. Swarupa and the panelists, regarding the self cycles only. I'm talking about the retrieval of 7 oocytes and that part, because we are talking about the OHSS, which can happen in the self cycle also. Does it hold good for the self cycle, or it is only we are more careful about the donors?
I think that 7 is only for donors, madam. For self cycle.
Yes. But that can happen even in the self problems. No, that OHSS can happen in self also. But maybe we are more worried.
Self pay, there is restriction as far as number of oocytes is concerned.
Yes, okay, fine.
So,
thank you.
I'm just
also the exploitation part is more with the donors, no, ma'am, not so much with the self. So
Correct,
probably
correct.
that's why it's
Exploitation
applicable more to the donor cycle.
I have not yet understood how have they arrived at the number of 7? I mean, what is the so this about this number 7? I'm yet to understand. I try to find out, but I have not got. Anyways, we move ahead.
Exploitation is one, and second problem is OHSS. We have to be more careful in the donor than self.
Madam, most of the times now everybody using antagonist. I think we hardly have any OHS.
Yeah, I don't use, but in general, I'm just talking about.
I just have to make
I think the
small
7th figure has come after 3, 5, 7 like this. Multiple figures have come after 7 is compromise.
Odd numbers किसी का मन में आया तो 3, 7. Anyways, I'm very sorry. I may leave for my OPD. So I'm just taking one more question. And meanwhile, Dr. Monica, please arrange for another screen sharing. so that, you know, till the time doctors are answering, we can shift and I'll stop my screen sharing. So now we are coming to age limit eligibility criteria for the clinic to determine the eligibility of the commissioning couple. Shatabdi, you can take this since you are doing this day in, day out. And I'm stopping my screen sharing.
Yes, ma'am. Yes, ma'am. The age limit for the commissioning couple is between 21 to 50 for the female and between 21 to 55 for the male. They have to be either legally married. Single women are allowed, although same-sex couples and single men are not allowed as per the law.
Okay.
Now, the only doubt which I have here is, suppose the girl is 19 or 19.
Yes.
Okay.
Husband is 23.
Mm-hmm.
And husband's FSH is around 14 or 15, and he has got very few sperms left in his, as per the semen analysis report. When can we actually stimulate this couple? Should we wait for her to become 21 and for him to become azoospermic and tell, sorry, there is no option?
No,
That is one.
I can suggest a way in this. Meanwhile, you can just freeze his semen sample. And then wait girl to become 21. That is
I think we have to wait, sir. Ma'am, I have got a couple of patients where the female is 20 and there is bilateral tubal block. But I have to still keep on waiting till she turns 21. I know she'll be requiring an IVF anyways, but I am not doing anything. I'm just asking them to take folic acid and come after a year.
Can somebody start sharing screen?
Yes, ma'am, I will be sharing the screen. Yes.
So individually, as Dr. Raghavendra asked, individually you can, I think, freeze the sperm, but don't fertilize. Just store karke rakho till the time girl becomes 21 years old.
Well, that's a common problem we face, because one person is on one extreme, the other person is in the normal range, and then it becomes very difficult for us to manage.
Okay. Thank you all panelists. I'm very sorry and apologies to leave this webinar in between. Dr. Rekha will take over from here. Thank you so much, all of you.
Thank you, Dr. Swarupa, for all your contribution and taking it forward so much. Thank you.
Thank you, madam.
Yeah, thank you. Fine. This probably, what has changed for the ART clinics practicing donor cycles? We spoke about the cell cycle so far. Dr. Raghavendra, can you tell us what are all the problems or the benefits, either way, that has happened to us now? What are the changes we are finding?
See, basically, if you look at from the female point of view, it is one donor per couple. So when you take one donor per couple, definitely the cost will go up. Cost of treatment goes up. Secondly, we can take only 7. You can take out how much ever you want, but 7 embryos only can be found. Others,
not the slide. Please keep the
so
proper
what
slide.
they said is, you can actually, if you have more number of eggs, you can take the eggs and freeze it, but only 7 embryos you will create and keep it in storage. Third thing is quite a lot of paperwork. We have to get the approval from the magistrate. I mean, not the magistrate. As of now, a notary approval is enough. We need to take a life insurance cover for the donor.
Donor.
Yeah. So
for at least a year.
Yeah, for at least a year.
Yes.
And that's mainly regarding the donor point of view. The semen point of from the semen donor point of view, again, we need to collect the IDs of the person who is donating and store it with us, keep it with us. And from the consent form which we have seen, unfortunately, there is the name of the donor. I mean, the details of the donor also was mentioned. So I do not know whether it becomes an anonymous donor or how to proceed forward. That is still one gray area which we have not yet tried.
But it is clear, no, now that it is the need not be anonymous, either egg
it
or
can
the
be your
donor.
known person.
Yes, it
Yeah.
can be known person for both male and female donors.
Just that it has to be routed through an ART bank.
Yes, yes. Everything has to be come through the ART bank. Even if they are known friend or relative, we have to tell them to go to the ART bank. The commissioning couple should enroute that, and everything should happen through that. Yes, agreed. And what about as you said, one egg donor for one female? What about the sperm? Is it only one male sample to one lady, or how is it?
When your ART bank is doing the things, it can be only one sample for one person. Previously, whatever sample we used to get probably was like a chow chow bath. A lot of samples used to be mixed and given. Right now, when you are conducting anything, it is feasible only to do one sample per thing. And I think the number of samples collected from one person also, there's a limit.
But what I'm given to understand is that though it is said one lady should get one sample, it is one thing is that in one sample what that comes from the bank, it should not be a mix of two people, that one sample. That's one thing. But I was also confused that that sample, that man, that sperm donor can give to other hospitals also, other ART centers also. That is mentioned. In that case, how it will be to one patient only, one lady only? Anybody can give some input here? Did you understand what I meant?
Yes, yes.
Yes, ma'am. It's not clear still, I guess, ma'am.
Yes.
Only one female should receive
that
the
is why.
sperms from only one donor. Yes, ma'am. One female should receive sperms from only one donor, but that donor is allowed to give his sperms, I guess,
to
more
other
than once.
ladies
It's not clear
also.
still.
Yes, yes. But
Yes,
the
yes.
clause is not very clear. They said in one
Not clear.
paragraph it says to one lady only, but in further paragraphs it says he can give it to the other centers also, where definitely it may not be this lady. So this is my confusion, and so I wanted some clarification. Dr. Girish, you want to add some input here? Or Dr. Gora?
Well, as you said, it is a confusion. It creates confusion. And now it so happens, let me be very frank, the law is framed. And then we always keep on seeking loopholes in the law.
Yes.
Okay. And these things will be settled only when the court judgments start coming up.
Exactly.
Because certain can't explain each and every word of it.
Yes.
But the loopholes we use one loophole. And if it is against the spirit of law, the court will say, no, you can't do this. So we are going to take a lot of time. So far as the court judgments start coming up, the things will become crystal clear in the future.
Because right now the ART registry system online is still not functioning. Now they say you can do only one donor in a lifetime. The donor goes to Tamil Nadu, finishes one cycle, comes back after 6 months to Kerala and tells, I am doing it for the first time.
Yeah, absolutely.
Then she'll go to Karnataka after 6 months and again tells I'm doing it for the first time. So unless the
but sir, he will be detected on the national registry.
Yes,
unless
they
it
have
is
to,
entered.
because the Aadhaar card
unless it is entered.
Yeah.
Yes.
Unless it is entered. The registry,
exactly.
Unless the
registry is not
Aadhaar
still
is
functioning
linked,
properly.
sir, nothing
Yes.
can be done. Unless the Aadhaar is linked in the national registry, we will not be able to do anything. And there's no way we can find this out.
Yeah, the system is not yet functioning properly. And secondly, a lot of places in India, still the inspection is not yet completed.
Yes.
And apart from that, gray areas in the law, only court will decide whether it is black or white. Yeah.
It is like it is stirring the hornet's nest. Everything was somehow going on in the smooth way. But now since many things are bombarded on us and ART banks, all are under a lot of confusion. Probably it will take another 2 to 3 years for dust to settle. And as Dr. Giri said, probably it has to be enrouted through court and get the proper judgments. And the RTIs probably will stimulate and create all this in a faster pace, and we get the judgments and some information for us to go through the proper streamlined way. Thank you. Next slide, Dr. Monica, if you don't mind. Yeah. Dr. Suyoga, can a couple get a friend? This probably we have answered this question. Get a friend or relative to donate the semen sample or the egg donor for them. If so, what is the clause? If yes or no, what is the clause? Dr. Suyoga, are you there? Dr. Doshi, is he there? Dr. Doshi, Dr. Suyoga? If they're not there, again, Dr. Raghavendra, probably I'm catching you.
Madam, they can donate. It has to be routed through a ART bank itself.
Yes.
ART bank.
Yes, and we have told number of times, all that we have already discussed on that issue.
Yeah.
Okay, now coming to the consents of
There are going to be a lot of consents in it.
Yes,
and you can
yes.
go to the rule book, which is 96 pages book.
Yes.
Well,
yes.
everything is there.
Yes, all different forms still for form 15 and all that, other than the consents, so many things. Okay, fine. Next slide, please. Yeah, talking about the ART bank. Next. Okay, now what are all the functions of the ART bank, Dr. Girish?
Yes, that is to retrieve the sperms, to collect the sperms, store them, and distribute them. That's the basic function of bank.
And what about the female?
Eggs and gametes. They have to collect the gametes from the donors. They have to freeze them, store them properly, and distribute them. That's it.
You mean the egg donor?
Egg donors. Yes, they can preserve the eggs also. No problem.
No.
Yes.
As far as my knowledge goes, others panelists can answer this question. The ART bank.
The recent amendments, the latest amendment says that for a sperm donor, they are supposed to select the sperm donors, register them, screen them for viral markers and all, and then store the sperm. For egg donors, they will be registering the egg donors. They will be getting the blood test done, screening them, and then sending them to the respective level 2 ART clinic for further processing.
Exactly.
Yeah, it has to be a fresh process. That's it.
No, Dr. Girish, they can screen for the egg donor. They can't store the sample, unlike men.
Yeah. Eggs are not. So you were
talking about gametes. No question of gametes there. It is only screening and keeping the female donors. And rest of the thing should happen in the level 2 clinic.
Yes, I agree. I agree with you.
Egg pickup and freezing, whatever should happen in level 2 clinic.
Right,
yes.
right.
So, yeah. So this is what the question was about. Okay. Next slide, please. Yeah, this is what we were talking about. Screening, collection, and registration of the sperm donor, cryopreservation. That is fine. Screening and registration of the oocyte donor. Operate as a semen bank, oocyte bank. Oocyte bank means just the data and get the data of the donors and maintain that registry. Fine. Next.
Right.
Yeah. The bank shall not supply the sperm or the oocyte of a single donor to more than one commissioning couple. So this first sperm we were talking about, we were discussing about, and we are pretty clear about the oocyte donor because it is 1:1, provided, as we said, that Aadhaar card is linked and information is very transparent. And oocyte donor shall donate oocytes only once in her life and not more than 7 oocytes. Yes, this also we spoke about. All unused oocytes shall be preserved by the banks for the use on the same recipient or given for research to an organization registered under this act after seeking written consent from the commissioning couple. We need their permission whether they themselves want to use it or can be donated for the research purpose. A bank shall obtain all necessary information in respect of a sperm or the oocyte donor, including the name, Aadhaar number. Again, Aadhaar number you should be fairly clear about that. It is not a fabricated, especially the identity of that person. The face should match. They should give a colored Aadhaar card because the Xerox Aadhaar card will not show their proper face. It will be just black. And the identity is very important, especially regarding the age and the address of that person along with the contact number, and the age should be that it should match. Like we were talking about the age more than 21 and all that. Otherwise, if it is much lesser, then we will be in problem of stimulating such a donor. So Aadhaar card as defined in the clause, and then address and any other details of such donor in such manner as may be prescribed. Okay, fine. Next slide, please. Yeah. I'll come to Dr. Day again because Dr. Suyoga and Gorak I cannot find. So can an ART bank supply the egg donor to the clinics located in different states? Like I'm in Karnataka, can I get it from Maharashtra?
I am a little confused about this, but I think it can be with permission, ma'am.
Yes.
I think.
Yes,
I'm not sure.
allowed. Yes, it is allowed. There is no problem. The transfer of the gametes of the embryos
Is
or the
allowed. But there has to be consent and a specific form has to be filled.
filled, and the national registry should be informed.
Yes.
So these
But
are the two important things there.
Yes.
Okay. Yeah.
Yes,
So the next
yes,
slide.
yes, ma'am.
Yeah, I think we are overshooting time. It's already 8:15, 8:13. Can ART bank stimulate and do OPO also? This probably we have already spoken.
Answer.
Yes, explain can ART, because when I made these questions, I didn't know that those will be answered much before. Anyway, can ART bank supply the stimulated donors? Yes, we have spoken about this. What should I do with extra gametes? This also just now we explained, isn't it? Like it should be taken consent and all that. Yes, all unused oocytes or embryos stored for 10 years used for the same recipient, then perish or take it for research. Commissioning parent or spouse dies, hand over it to the living spouse or the research. But again, the consent is very much important. Whether to give it to the spouse also, the consent is very much important, not only for the research purpose, because there may be some problem among them and legal issues and all that. So provided the consent has been taken before, then yes, as an ART bank may, for such appropriate fee as may be prescribed, store any semen obtained from a donor or the exclusive use of the wife or a partner of the donor. Record of such, that is 10 years, then send it to ICMR. Yes, this is very clear. Next slide, please. Yeah, this is a big slide. The pre-implantation genetic testing shall be used to screening the human embryo for the known pre-existing, all this, everything. Yes, agreed, provided we have informed the national registry and provided we have taken the proper consent for all. Like if the wife dies, the husband dies, both of them die, everything, provided you have mentioned everything in the consent form, taken consent of both, then yes, and the national registry being informed. Next slide, please. The grievance redressal. Anybody wants to explain about the grievance redressal? How it should be in level 2 clinic? Is it must? What it should comprise of, etc. when they come for inspection? Dr. Agwendra?
Ma'am, the form is given. Yes.
Okay, tell me. Please proceed. No problem.
Ma'am, the format of submitting, actually the grievance redressal, they say it should be in an ART bank as well as in a level 2 clinic.
Yes.
So the format of submitting the grievance is that form 5 that is there, but who should be a part of the grievance redressal is not yet mentioned in the act. So we don't know who should be a part of the grievance redressal. We just have the format for submitting our grievance.
Yes, exactly. The
madam, when we underwent inspection here, it was specifically informed that when you're having a grievance redressal committee, you should have at least 4 or 5 members in it, and one of it should at least be a lawyer who is well versed with the act.
Okay. Other than that, the gynecologist, the counselor and all that. So totally comprising 5, but according to the law, it is not very clear. Maybe at the inspection site, they have particularly mentioned, but as Dr. Shatabdi said, the law itself does not explain all this in detail. Next slide, please. Yeah. Is that okay? Advertising and marketing by the ART clinics, is that okay? Is there any clause in that? Dr. Raghavendra?
I don't remember going through, madam. Because basically when you're giving marketing, as of now, all the marketing is only for paper marketing. Right now, 90%, 99% of it is gone into online marketing. And as of now, there are not many laws regarding online marketing.
Yeah, but probably as far as my knowledge goes, I am subject to correction. The advertising for the egg donors or the sperm donors is quite okay. Is that right? What I'm saying?
Yes, it is correct.
Yes.
You can invite donors by advertisement.
Yes, exactly. That is the main part of the advertisement.
But the bank has to do that. The bank has allowed.
Yes, bank, exactly. The ART bank I'm talking about.
Yeah.
Yes, you are right. Thank you. Next slide, please. Yeah, offenses and penalties. The sex selective ART is 5 to 10 years or I think it is plus, as I have gone through, it is plus 10 to 25 lakhs. Maybe it is or. The first contravention is 5 to 10 lakhs. It's the first mistake what you are doing. The subsequent way is 3 to 8 years and 10 to 25 lakhs. So S34, that is according to that section, whoever contravenes any of the provisions of this act or any rules made thereunder for which no penalty has been provided in this act shall be punishable as per subsection 2 of the section 33. So ultimately, it is something similar to the PCPNDT Act, where the first offense and the subsequent offense is the really matters, where it is a non-bailable one, especially the sex selection is a non-bailable, non-compoundable, plus there is a lump sum money also as a fine, or the huge hefty penalty is added in that, and it is non-compoundable. What I mean by non-compoundable is it cannot be understood, or it is not a understanding between the two parties, that is a commissioning couple or the donor and between us. It is beyond that. You cannot adjust among yourselves. These are the offenses and penalties. Next level, next slide. Yeah, offenses, no court shall take some slides I made and some slides Swarupa made. So no court shall take cognizance of any offense punishable under this act, save on a complaint made by the national board or the state board or by an officer authorized by it. Offenses to be cognizable and bailable. No court inferior to that of a metropolitan magistrate or a judicial magistrate of the first class shall try any offense punishable under this act. What we were talking about previously was especially on the sex selection. That is a major criminal act, or that is a major offense. Anybody wants to add some input here?
No, ma'am, it's clear, I guess. Yeah.
Yeah. Okay. Thank you. Next slide, please. Yeah. Anybody wants to talk about this? I don't run the surrogacy clinic. Anybody wants to add about surrogacy? Well, the thing is, it has to be altruistic surrogacy.
It's a big topic, I suppose. It's a
because we are running out of time.
Yeah, it's a big topic.
One thing about surrogacy is it all has to be altruistic, at least on papers. It should not be a commercial surrogacy. Though practically how much it is feasible, I'm not very sure. Who will come to rent their body as altruistic? Not very sure. This is one part among the.
Also like social surrogacy was allowed earlier, ma'am. Now there are specific indications for which we have to do surrogacy. Only then we should go ahead. Yes. And the additional, the certificate eligibility and all that.
Insurance.
So it's a big topic.
Yes, her insurance, everything. And another thing about the surrogacy is something I forgot. Okay, fine. Sorry. Next slide, please. Something I wanted to tell, I forgot. Okay. Yeah, what are the cons? Strained relationship. Regarding the cons, the strained relationship, less safeguards and cost. The pros would be the cost, the familiarity, and accessibility. I didn't understand this. This Dr. Swarupa has made this slide. Next slide, please. Yeah, anybody wants to talk about the surrogacy? This part all of us know, isn't it? The age of surrogacy should have one child and all that. The one thing I just wanted to clarify here is, as far as my knowledge goes, she cannot be the egg donor also. It is like either.
No, ma'am. It has to be gametes from both the husband and the wife. No donor gametes are allowed in surrogacy, ma'am. Earlier it was said, in the initial act, it was said that one should be self and one can be a donated gamete. But the latest one says that donated gametes are not allowed. It has to be both self.
Okay. My question was, can she be an egg donor previously? The surrogate can play a role of egg donor previously. Is that allowed? Because to my clinic, some patients, when we ask for the egg donor, they say, "Maine pehle surrogate thi," aise. So can they have the two roles in their life? That part I'm not clear.
Not mentioned anywhere. As far as I remember, not mentioned, ma'am. I don't know.
Madam, she can donate her life. She can donate her ovaries only once in her lifetime. She can donate her uterus only once in her lifetime. She has donated the ovaries.
Right.
Now she can donate the uterus.
Yes, can she? That means that one role she can do both of each. Na? Once egg donor,
once in lifetime.
Yes, she can. She can.
That confusion, because I was not very clear on that part. Fine. Thank you. Next. You can go fast, I think, Dr. Monica, on this. The couple shall not abandon the child after birth for whatever reason. He has common sense. Rights of the surrogate child. The child born shall be entitled to all the rights and privileges, like it is considered as the natural child of the commissioning couple. They have accepted the child and they should give all the rights. Number of oocytes or the human embryos to be implanted shall shall transfer one embryo in the uterus. Is a single transfer in the uterus of a woman during the treatment cycle. However, only in explainable circumstances, like previously she has lost like RPL or recurrent implantation failure.
Previous abortions, recurrent failures, age, more age on the higher side.
Elderly woman, all that more than 35, all these are the cases where do we put more than one. It's not the single embryo transfer all the time, except for those conditions. If everything is within bracket, it has to be a single embryo transfer. Prohibition. Okay, fine. Offenses and penalties. This probably has already come once. We have spoken about this. Yes, this also we have told. This also had come. Okay. Will this act help to regain the lost confidence among patients, among the government? What do you all feel? Will it bring more transparency, more honesty? What do you all feel? It's a general question.
This will bring in more bureaucracy. Bureaucrats will play their games very well.
Yes.
Patients will feel the pinch because every treatment cycle is going to be expensive.
Yes, because every single donor, everything single.
And when the treatment cycle becomes expensive, automatically the doctor also will start feeling the pinch later on.
And it's going to bring in judiciary also.
And for us, another problem is dearth of the donors, the egg donors, because the dearth of surrogates also. Another important pinch, what we feel is a 7 oocytes. That is a big problem for us because sometimes that you may not succeed at all with 7 oocytes, and then the entire process has to come. So in which case, probably it is more tempting for us to keep more eggs or the embryos, the freeze, and not put it in the record. So the transparency is a question, because practical points are entirely different, and we are under more pressure, and working under the inside that social frame becomes more difficult for us. So I feel it is more problematic to doctors, the patients, the ART bank, everybody, and probably the legal issues are going to become more. The maintenance of records are going to be very, very strict. Ultimately, it's a problem for one and all. Probably, as Dr. Raghavendra said, probably for bureaucrats that is the one which will help them, because they are the ones who are implementing and making rules, and we are noose is tightened around us ultimately. Thank you one and all for your vibrant participation. I too was one of the panelists in this, not the moderator, because I too had a lot of questions and I shared with you and enriched my knowledge and got a lot of information. We here acknowledge the presence of Dr. Neeraj Nagpal also. Sir, would you like to add some input since our expert moderator is not there, Dr. Ashok?
Anyway, thank you. Thank you for getting us participated in this event. Thank you very much. Yeah. Thank you, Monica, and thank you, everybody.
It's a collective effort from all of us to understand the law. Thank you, one and all.
Thank you all.
Thank you, ma'am. Thank you so much, ma'am. Thank you, ma'am.
Thank you, Dr.
Thank you so much, all the panelists, and thank you so much to the moderators. We now move on to the second session for today, third session for today. For this, I would like to call upon our chairpersons for today, Dr. Bharti More. Dr. Bharti More, madam, is MD, FICOG, CIMP. She is consultant obstetrician gynecologist and fertility specialist at Airoli, Navi Mumbai since 1990, past president of NMOGS 2013-2015, organizing chairperson AMOX, and she has interest in music. Our other chairperson for today is Dr. Mansi Vasade, who is Secretary Chandrapur OBGY Society, past Secretary WDW, past Treasurer, and life member of PCOS Society of India. I welcome both of you, madam. Over to you to introduce the speaker.
Thank you for that fine introduction. Good evening, everybody. The speaker who's next is Dr. Neeraj Nagpal. Neeraj Nagpal is a medical legal expert, and he is a national figure. The introduction has been given to me And in a moment's time, I shall introduce him. He is MD, FIMSA, FISG, consultant physician and an endoscopist, chairman and managing trustee of MLAG, ex-president IMA Chandigarh State Branch, director Hope Gastrointestinal Diagnostic Clinic Chandigarh, is member of ASGE, ESGE, ISG, INASL and SGEI. Most important, he is fellow of International Medical Sciences Academy, Indian Society of Gastroenterology. And a lot of Accolades, member of editorial board, Indian Journal of Cutaneous and Aesthetic Surgery, member editorial board of Journal of Indian Medical Legal and Ethics Association. He has books edited, Compendium of CPM Medical Judgments and Medical Legal Aspects of Dermatology and Plastic Surgery. He's published many research papers at international and national levels and is awarded multiple orations as a speaker on medical legal issues at various conferences. Over to you, sir.
Thank you very much, ma'am. I'll try and share the screen.
Please allow sir to share.
The question that ma'am was asking was, what are my views on this ART and Surrogacy Act? It is very, very clear when BCPNDT came in, I was, of course, in IMA Chandigarh and quite prominent there, fighting with everyone. So the first thing I did was sell my ultrasound machine. I never did ultrasounds after that. My wife is a gynecologist. And everybody asked me why. And my answer was, I don't want anybody standing over my head and telling me what I'm doing, how I'm doing, and I don't want to follow this law. For that one reason, I have not repurchased an ultrasound machine or done ultrasounds ever since. ART and surrogacy, they are bills which have been made into an act. The main purpose to me seems to be to make the law so complicated that a law-abiding person will not be able to follow it. And once he can't follow it, he becomes open to blackmail, open to extortion. And we have seen this in PCPNDT. I do not know what your experiences are in southern states. In North, it is a routine business that you have to pay monthly if you want to practice obstetric ultrasound. So this is exactly what is going to happen here also. It is like prohibition in Gujarat or prohibition in Bihar. Basically, you have made a law. And what was the so urgency, such a hurry in making it if you needed so many amendments immediately after? Why was this consultative process not done beforehand, before framing these laws? So that is my 2-bit on this. And the topic given to me is very, very extensive. I don't think we will be able to cover it in the limited time. But if you want a gist of what laws a medical practitioner has to know and fulfill, it is endless list. Last we calculated, I think there were 92 odd laws. So it is just not possible to cover them in a short while. And already we are running short of time. You have laws when you are starting a clinic. There are professional aspects, there are labor matters, there are when you're commissioning a hospital, so many things. And it is very, very easy to fall foul of any of these laws. But I will focus on some important ones which you should keep in mind, even if just by the name of the law, so that you don't fall foul. One of the biggest problems is what we find is doctors start a clinic, start a nursing home. Initially, when the clinic is started, it's not a problem. But when they start a nursing home in the same premises, then later you realize it is a residential premises, not a commercial premises, and change of land use has not occurred. By that time, 10, 12 years down the line, you are well established. And if now you start getting notices backdated from the time, because now you have registered in various government, with various government authorities, whether it is PCPNDT, whether it is biomedical waste, whatever. So effectively, the change of user, the misuse charges will be calculated from the day you have started practice. And at least in Chandigarh, one of the doctors here got a misuse charge of 80 lakhs. So I don't know whether this is high or low according to what people in Bombay would feel. But fact remains, this is something we should look at before or just when we are starting practice. And this is not to be ignored, that we have to start practice in a place where that practice is permissible. And if change of land use is needed to be done, please do it. Then Clinical Establishment Act. Again, people will be attending here on whom Clinical Establishment Act may not be applicable as yet, because it is still limited to a few states, like around 12 of them and some UTs. But the fact remains, the Clinical Establishment Act in some form or the other is going to be adopted by all. And if we think this is a problem only of a few people, only of some states, and will not affect us, please believe me, what you have faced under PCP NDT is nothing what you are going to ultimately face under Clinical Establishment Act. There is a huge political motive, political agenda behind Clinical Establishment Act, which people have not realized so far. The main purpose of this act is that government just does not wish to spend on healthcare. And we have drumbeated ourselves into believing that health is a fundamental right. According to Supreme Court judgments, according to what we have said on international platforms, we agree it is a fundamental right. We agree it is the government's duty to look after the health of its citizens. But when it comes to putting money into healthcare, there we are very big laggards. So 75 to 80% of the healthcare was anyway being provided by small and medium healthcare establishments, and these were nearly all private. The corporate hospital has a very, very small percentage if we look at the total percentage share of care that corporate hospitals are providing, even now. So the problem which arises is, once the private sector is now being regulated through this act, effectively, you and I become servants of the government. You and I become servants of the bureaucrats who have to toe the line, who have to do what is ordered to us, not only under Disaster Management Act as happened in COVID, but even otherwise. They can tell you, they can ask you your statistics, they can ask you, I mean, I'm not the employee of the government, but I will have to provide any data, any and all data which is required by the appropriate authorities. And I will have to do what is asked to me by those authorities. I will have to charge rates which the authorities tell me you have to charge. This is the kind of thing, and they are going to come up with protocols, and you have to follow exactly according to those protocols. Any deviation over there, India is a diverse country. You cannot impose what happens in All India Institute of Medical Sciences to what is happening in a village in Bihar. But our ivory tower specialists come up with standards, and these are the standards which are going to be imposed through Clinical Establishment Act. And if you want to practice, you better be registered, because the only penalty is your registration will be cancelled, which means you can't practice. Then Consumer Protection Act. Consumer Protection Act 2019, the less said, the better. If I have to give you an example, January 1st, 2022 to 31st December 2022, we had 99 cases of medical negligence decided by National Consumer Dispute Redressal Commission. 926 decided by 34 state Consumer Dispute Redressal Commission and 9 satellite circuit benches. So effectively, there are total 45, and of them 34 only have uploaded, and 926 is their figure. We are not discussing the district commission at all. If the proportion we are seeing here, if we extrapolate that the number of cases in state commission were 926 and in national commission they went up to 99. So if we extrapolate that to the district commission, effectively that means 8 or 9,000 cases are decided by the district commission in this period. So that means a total of nearly 9,000, 10,000, let's say an approximate 10,000 cases are decided in 1 year. Now these 10,000 cases, keep in mind, these are the ones which have been decided. There are cases which are pending in courts, the number of which will be at least 10 times what the number of cases decided are. And do not forget, the settlements, the out-of-court settlements that doctors do, the cases just don't come to court. And that number of settlements is nearly 5 times. So if you ask me what is the actual figure of clinics, hospitals, doctors who are undergoing a dispute currently, the figure is around 5 lakhs at any given time. What is the total number of doctors we have? 12 lakhs, out of which some will not be practicing. Can you understand the immensity of this? Do you know today we have judgments of 9 CR, we have judgments of 1.5, 1.6 CR, 2.2 CR. How many of us can afford to pay this? We are all very happy to say indemnity insurance will pay. Indemnity insurance is not viable. Believe me when I tell you this thing, the number of cases which are coming up, the insurance companies are going to hike their premium more than by 5 times. You wait and see what happens in the next 3 to 5 years. National Medical Commission Act. We allowed this to happen. It changed the character. We are not even an occupation now. It is a trade. The basic definition of profession, which requires self-regulation and autonomy. Both these things have been taken away when we talk of National Medical Commission Act. Neither do we have self-regulation, because we are regulated by consumer courts, we are regulated by high courts, we are regulated by Supreme Court, we are regulated by the various authorities under various quasi-judicial fora. There is no doctor sitting there. So there is a question of self-regulation. And National Medical Commission or State Medical Commission is not the only authority which is regulating us. We are regulated by so many others. So self-regulation cannot be claimed. Where autonomy is concerned, look at the composition of the National Medical Commission. We are agreeing that 70%, 75% of the healthcare is being provided by small and medium healthcare establishments. Where is the representation of this 70, 75% in the National Medical Commission? There is no elected representative. There are 9 people who are nominated from among the elected representatives of different states. They are also ultimately nominated. So let us agree and say that with this coming of this, we are no longer a profession. If we are no longer a profession, why do we talk of nobility of profession? Why do we think in terms of professionals? Let us be a business body. Let us be a trade body. MTP Act, you people know much more than me. PCPNDT, again, you people know much more than me. Transplantation of Human Organs Act, we all have to be aware what is happening where. Surrogacy, as I already mentioned, simply what they have created is such a mess that even experts are not clear what is to be done in what situation. So some people will become victims, some people will be the casualties in this process when people are trying to understand the law and trying to follow the law. Fire and Prevention, Safety and Act and Rules. Please understand that under Fire Rules and Fire Act, there are certain things which have to be done when you are starting a place. If you have not done that, you can't add these things on later. Similarly, the lift, once you install a lift in your premises, there are certain things which have to be done. It has to be licensed. POSCO Act, you have to be very, very careful and knowledgeable exactly about it so that you do not fall foul. And later, because the penalty under this act is so tough that many doctors unknowingly and unwittingly have fallen foul of this. Criminal Law Amendment Act. You have to know that this act is made, it is notified, it is very clear under this act that what you have to do is, in the cases of rape, is you have to provide treatment. And it is not limited to a first aid. If you have facilities and infrastructure, you will have to treat and stabilize and do whatever is necessary for the patient. Drugs and Cosmetic Act, such a draconian thing. Any drug inspector worth his salt can harass you, and under those circumstances, you can land up into a major problem, especially if you are dispensing medicines, or you have a counter in your hospital where a pharmacy is running. You need to know NDPS Act. You need to know ESI, EPF, income tax, GST laws, Indian Penal Code. Don't forget this. Indian Medical Council Professional Conduct and Regulations 2002, which are applicable now, but 2022 new regulations National Medical Commission had come up with, put it in the public domain. We have given our representations on what we want in that, because as usual, they have created a bloated booklet. And in that bloated booklet, there is only one right which has been given to the medical practitioner, that is that he can charge for his services. I'm so grateful for the government to have considered that right for me. Biomedical waste management and handling rules, please keep this in mind, that these are things which you will fall off when you start a practice and you are not knowing about this, because ignorance of law is no excuse. Nobody is going to excuse you on this ground that you did not know the law. So I think with the shortage of time, I will just restrict myself to this, because I can go on and on for 3 hours. But in case there are any questions, I'd prefer to take that. Thank you so much.
Thank you so much, sir, for the wonderful. Thank you so much, sir, for the wonderful inputs from your side regarding all the laws connected to medical fraternity. And thank you all the faculties and all the organizers for inviting me as a chairperson for this wonderful webinar. Thank you so much. Over to you, the MOCs.
Dr. Monica?
Doctor, hey doctor, काय झालंय गेलो बघ लवकर ये. I have to say thank you. The meeting is over. थोबड़ा तो दिखाऊं मैं.
Sir, after the chairpersons finish, I had 2 questions to you before we disperse. Dr. Bharti?
I think she's on mute.
Yeah. So can I ask chairpersons, with your permission, and Monica, Dr. Komal?
Yes. Hi, I am there. I think it was an excellent talk by Neeraj sir. Very, very rightly pointed out so many laws which we, the obstetrician and gynecologist should take care. I think fabulous talk, and you can put your inputs, Dr. Rekha.
Yeah, thank you. If you have any input, you can tell. Otherwise, I had 2 questions to ask Dr. Neeraj. Sir, I had 2 questions. One is why, for what reason it is not a bilateral decision that is made, whichever act you mentioned, why our woes or complaints or the difficulties are not heard from the government, why it is always a unilateral decision that is taken by the bureaucrats, and we are put at a lot of difficulties because of this.
There is a reason behind it, because it is people, our people, who are sitting in ivory towers, who are advising the government. If I give you the recommendation All India Institute of Medical Sciences had given for what is the human resource requirement for a 10-bedded ICU. You will be shocked to see, and if we calculate by that requirement, no small hospital can ever run an ICU. But this is the recommendation given by All India Institute of Medical Sciences. And government is going to impose that when it comes to be imposing this on Clinical Establishment Act. This is the problem. They take technical input, but they take technical input from people who have no idea of what is happening on the ground. We do not have representation from small and medium healthcare establishments, nursing homes, hospitals, less than 20-30 beds. These are the people who are providing bulk of the services, and they have no say. They have absolutely no say, neither in IMA nor they are in the National Medical Commission. They are simply to be regulated. Their opinion has no voice. This is where the problem lies. We have, you imagine, National Medical Commission, what is the comprise of? Medical universities will nominate one person who is usually the chairman of the medical university. What does he know of a small 10-bedded nursing home running in Kolhapur? What are the problems he's aware of? But all universities have representation in National Medical Commission. This was happening even in Indian Medical Council Act. It was happening in MCI also. But still there was so much elected people who were going that at least some representation was there. The biggest problem is it is our own doctors who are sitting in institutions who are feeding the government with information, which is okay if you look at it from their angle. But when it comes to ground, the problem is there.
What can we do that our smaller sectors are represented? What step can we do?
We should have done then, because from Medical Legal Action Group side, when National Medical Commission Act came, we made a very, very strong representation that this is the formation has to be representative of the profession. You cannot nominate director from PGI and director from AIMS and all these places and expect them to be looking after the interest of the healthcare of the country. The healthcare of the country is not in the hands of these medical administrators, because these medical administrators are turning out to be worse than bureaucrats, actual bureaucrats. What we need is doctors on the ground who should have a representation.
Yes, exactly.
This is where the difficulty lies in the system which is running today.
Yes. Sir, I had another question. Like, as you said, in the court of law, there are a lot of consumer court or criminal cases, whatever. There are a lot of cases, doctor versus patient. And as far as my knowledge goes, it is majority of times when it comes that the doctor is guilty, he has to pay some amount, huge sum, whatever, to the patient. The vice versa does happen. Does it happen? Like the number of doctor being penalized versus patient being at fault, feeling guilty, is much less. I feel the ratio is much less. Even the
frivolous complaint is what you are asking of. When there is a frivolous complaint made against the doctor, so under Consumer Protection Act 1986, there was a clause which said if a patient filed a frivolous complaint against a doctor, he would be penalized, and that penalty was humongous, huge, 10,000 rupees. He was suing you for 2 crores and the penalty for him was 10,000 rupees. And you have spent more than 2 lakhs on legal help to win that case. But this was also not acceptable to our government. And when they came up with Consumer Protection Act 2019, they removed this clause of frivolous complaint being penalized. Because according to the government, probably it was too much of a burden for the consumer. 10,000 rupees was the penalty, and now in the new act, there is no penalty for a frivolous complaint.
In the criminal cases, when the patient is...
Ma'am, you're not audible.
Yes, maybe my connection is not very clear. I don't know.
Ma'am, now you're audible. You can ask your question now.
Yes, only one question I had. And that means it encourages the patient indirectly to trouble us a lot. And the second thing, even if it is outside the ambit of CPA, even in the criminal cases, the doctors are supposed to pay out of proportion to the patient. And that is not exactly what the patient has to pay us. Like they would have defamed us, taken a lot of our time, our important quality hours, everything. That also mounts, no, sir. But the penalty is not so much.
I am working in this area since 1994. The first book I wrote in this area of medical negligence was in 94. I must have had at least 200 doctors who have, when they were in trouble, they have approached me, asked me my opinion, sought help. At least 200 of them said very clearly, let me win this case. I will see this patient that he bleeds so much that he will never dare do anything. None of those 200, after the resolution of their case, ever had the gumption to sue the patient. We do not create a deterrent. Our problem is there is something called a broken window hypothesis. If somebody just throws a stone at your window and you do not take action, next time he will throw a petrol bottle into your house and you will burn down. So you have to stop the crime at a lesser level before it escalates. And we have allowed Consumer Protection Act to become a dragon from what it was. Before 1986, there were a total of 3 cases on medical negligence in jurisprudence from Supreme Court. After that, I'm giving you the figures now. And if you realize what I'm saying, 1 in 3 doctors will be involved in a dispute, whether they have settled, whether the case is in court, whether the decision has been made at any given moment. Can you realize the implication of this? And criminal courts do not give any major compensation. Even if they order compensation to be paid by the doctor to the patient, that also amount is not much. They allow you, to the patient party, to sue you under civil laws for actual compensation. But if your criminal case is rejected, if you are acquitted from that, there is no, you don't get any money from the criminal court. Yes, we have put you in jail for 1 month, and now just the fact that you are acquitted, you are thankful. Yeah. You say, thank you, I don't want to see the police, I don't want to see the inside of a court, I don't want to see the patient ever again. This is the attitude of most doctors, and it is unfortunate.
Very defensive
because we
attitude.
need to create deterrents so that the next time they try to do something like this, they have a deterrent. They know, yes, this we had done there, and this is the kind of result. If one patient party who sues unnecessarily is fined, let's say 1 CR, let me see how many patients come after that. The problem is we do not create a deterrent.
We do not create a grid, but the court is also, it seems, very partial towards them.
Court don't expect anything from the court. अगर बच्चा रोएगा नहीं, तो माँ दूध नहीं देगी. आप कोर्ट से एक्सपेक्ट क्यों कर रहे हो? आपने कोर्ट से मांगा जाके? आप तो जब छूट गए, आप भागे वहां से कि मैंने तो अब दोबारा इसकी शक्ल नहीं देखनी. आप जाओ कोर्ट, मांगो कि जी मेरा आपने 1 महीना बर्बाद किया है. This is the loss I have incurred. I was earning this amount beforehand. This is a frivolous complaint. I should be recompensated for this. Nina Rajan Pillai. Rajan Pillai was chairman, managing director of this Britannia Biscuits. So he was incarcerated in jail for some economic offense, jo inka tax matters or something like that. Tihar mein tha. So he was a known serotic. So when he was arrested, he informed the doctor, jail doctor, that look, I am a serotic and I have problems and I should be permitted to show to my gastroenterologist at All India Institute of Medical Sciences. It was refused. 4 days later, he was found dead in his cell after a massive bout of hematemesis. Now this is Britannia Biscuits chairman. What is the compensation which was awarded to Nina Pillai, who was the wife of this guy? 10 lakhs. But a doctor who is trying to help, fails to help, can have to pay 10 crores. I mean, the irony of it is just not percolating. हम जितना वो जाल बुनते जा रहे हैं, हम उनके जाल में फंसते जा रहे हैं. We are moving from one clause to the next. ये हो सकता है, उस साइड हम पिक कर सकते हैं, नहीं कर सकते हैं. We are not seeing the bigger picture.
Yes. Okay.
Basically, government doesn't want to invest into healthcare. They want the private sector to be under the thumb of bureaucrats, whether they are medical bureaucrats or actual bureaucrats. And what is happening is that if a law is passed today and you need to pass 10 amendments in the next year, what was the business of passing that law in the first place?
Yes.
It creates so much confusion.
Has created.
I'm sorry, my views are very radical. So
No. We understand, we appreciate that. At least I appreciate that because I am of that kind of mind. Thank you, sir. Thank you so much. Thanks, Monica, for the opportunity. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Manisha ma'am, your comments, please. Bharti ma'am, can you sum up? I cannot see Manisha ma'am.
Can I talk?
Yes, ma'am.
Yeah, good evening, everybody. This was a fantastic program that was conducted because there are many loopholes and many queries that the new people who are going to start ART, like, the newer people who are going to start IVF centers. Like now, so level 1, 50,000 has been paid 1.5 years back. Still nobody has come for inspection. There are new ART clinics like level 2. They have, everything is ready. They have given applications and still people have not come for inspection. So now what is to be done with such cases, sir? My question to Dr. Neeraj Nagpal.
Look, you have to make a representation under RTI. You have to ask the authorities what is happening to my application. They do not reply. You file a writ. This is violation of Article 19, right to practice your profession. You are qualified. You are a professional ART specialist. You are not being permitted to practice your profession because of delay on the part of authorities. But how many of the young doctors will have the gumption to go to High Court on this matter?
Exactly.
All of us you ask me what can be done, this is what can be done.
Right.
But nobody wants to upset the appropriate authorities.
We'll bell the cat. That's it.
But that is the whole point.
But under the PCPNDT Act, if once you have submitted all your papers for registration or renewal of your machine, if they have not applied within 90 stipulated days working days, then it is considered deemed as a renewal, automatic renewal, if there is no response from their side.
Ma'am, there is no legal precedent to this. There is not one case across the country where there is a legal precedent of this issue, where a dispute has arisen and this clause has been invoked.
Okay.
Madam, I'm talking about the new people who are starting, not the renewal.
I told about PCPND.
Yeah, that's what. I'm talking about the new level 2 ART centers to be started. They're all set, so much of money invested, and they're not coming for inspection, so they can't start the clinic. So there, what Dr. Nagpal is saying, I think all of us have to get together and do that.
Yes.
Yes.
Thank you so much, sir. Thank you.
Now there is a notification, the Gazette, that they have to make a subcommittee which will make the inspection teams under the medical officer health of their respective districts, and then they will take care of the inspections. This notification has come, ma'am, last month by the efforts of Dr. Mandakini Meg, madam, ma'am, at least in Maharashtra.
What, Dr. Monica, please repeat.
Ma'am, they have instructed the medical officer health of each district to form a committee and then go ahead, because nobody knew what exactly the committee was like. So there is a Gazette notification that has come about what exactly should the committee be and who is supposed to make those committees. So we can approach the medical officer health of each district or the civil surgeon in that particular district in case of a rural area, and they will make the committee, ma'am.
So that is a state level inspection.
Yes, ma'am. So once that body is formed at district level, then they will conduct the inspections. Because we have been instructed to pay, and we have been just given one letter that you have paid and your inspection is done. We will give the certificate once the format comes from the government side. We have not yet been given the certificates now.
But certain centers are given the registration certificate.
Solapur, they haven't given, ma'am. They have just given one in writing on their letterhead saying that we have conducted the inspection and you have paid, so you can go ahead with the procedures right now. As and when the format comes, we will give you the certificate.
Okay, fine. Thank you.
Ma'am, there was one question in the chat box, if you can take it, whether the ART bank and the ART center itself can run in the same premises.
There was a question once in AICOG, the same question, but I think as far as the answer, what they had given there was beginning, they said no, but later on probably they amended and they said it can be together or something like that. I'm not very sure of that.
No, it is no, man.
Beginning, they
It
said
cannot
no.
be in the same
No.
building.
Yes.
No.
But
ma'am, if the proprietorship is different on
see that's what there's some clause that
if it is on a different name and if the proprietor is different, then it could be in the same premises.
And registration is separate for two things.
Yes,
if
ma'am. Both the things should be separate.
Yeah. That is what I just was little out of confusing me.
Oh, you mean to say in the same premises as the ART clinic, doctor?
Yes. And bank.
Yes, ma'am. In the same premises, the clinic and the bank can run, provided the proprietorship is different, ma'am. And both have applied for 2 different registrations.
Yes.
Okay.
Yeah.
So each one has to comply their own formalities, ma'am.
Yes. So that is what I was trying to express.
This is not, it can be in the same building.
Yes,
yes. But it should perform as 2 entirely separate things.
Separate entries should be there.
Yes.
Separate entry, separate record keeping, ma'am, and separate compliance of laws.
Right. Okay. Thank you.
I think, ma'am, that should be all, or we should continue the discussion further if there are any questions remaining.
Thank you, Monica.
Thank you, Monica.
Thank you. I invite forward, ma'am.
Conducted very well.
Thank you,
nice
ma'am.
program.
Yeah, very well conducted. Yeah, you performed very well, been working since a long time to make this a successful program. We can understand the hard work.
Thank you so much. Can I invite Dr. Komal ma'am to please officially propose the vote of thanks?
Yes.
Thank you so much, Dr. Monica. And it gives me immense pleasure to thank all of you. I think it was a lovely session. A lot of insight to the medico-legal discussions happened today. And I think Dr. Neeraj Nagpal sir, your talk was the icing on the cake. You solved so many queries. And the wonderful panel discussion. Dr. Rekha, you're fabulous. She and Swarupa with all the panelists, Dr. Bharti Madam being till the very end, I think it was a fabulous.
Good evening, Komal, and all the best.
Thank you so much. So lovely discussion, a lot of learnings today. I think so many people who are not able to join and we are seeing from the YouTube, they have asked for the recording also. So it will be circulated live recording to all of you so that you can take the benefit, because this is really going to benefit into the day-to-day practice of all our colleagues.
I want to have the recording because my busy Monday OPD, I really couldn't attend the whole.
Yes, I think this is how it helps. And Dr. Pardesi sir, Dr. Sujata Darvi madam, President and Secretary of AMOX, thank you so much. Thanks Alka Kriplani madam for being here. And Monica and Pratibha Baldava, our MOC, I think she's done a fabulous job. So thank you so much and hoping to see you in the next webinar. Thanks a lot. Good night.
Thank you everybody. Thank you so much.
Thank you, Dr. Komal and Dr. Monica and Dr. Pratibha. Thank you, Dr.
And thanks Shield Connect team, Sahiti. Thank you so much.
Thank you, sir, for solving our questions.